A very good morning to all the ENT surgeons across India. This is Dr. Urvi Mistry from the medical team of Abbott, and on behalf of the entire team of Abbott, I cordially welcome each one of you to this ENT live surgery demonstration on rhinoplasty. Today, we have with us a renowned rhinoplasty surgeon from Jaipur, Dr. Sunil Tanwar. Dr. Sunil Tanwar is the director of Jaipur Durbin Hospital and Naksh Rhinoplasty Center. He is the founder secretary of the Rhinoplasty Society of India. He is certified by the International Board for Certification in Facial Plastic and Reconstructive Surgery. He is also the director of Global Rhinoplasty Fellowship Training Program. So we are truly honored to have you with us today. And with that, I hand over the stage to you, sir. Thank you.
Thank you. Thank you for a nice introduction. Uh, First of all, I welcome really all of you in this live rhinoplasty webinar session. And my heartfelt thanks really to the Abbott, Mr. Satish Sharma ji, the JBM of this entire medical team, and Dr. Urvi and the Himal, because last 1 month throughout doing the continued exercise just to make successful this program. So my heartfelt thanks to you. And today, I think in this live rhinoplasty webinar sessions, we have some different part. Because first we discuss regarding how you start the rhinoplasty career, and then we discuss a photograph of the patient, and then we start the case. So, like everyone, really the rhinoplasty is one of the most complicated surgery in rest of all of plastic facial plastic surgery. So you should have a systematic manner, because in rhinoplasty really we have a lot of challenges, like because it's the cell a lot of endless anatomical variation of the nose, and this surgery need the form and function, and your cosmetic and the functional both aspect that should be balanced, and your result that should be matched with the expectation of a third person mind. So these factor make it a complicated surgery in rest of the all of facial plastic surgery. So how you start when you think, then I want to become a good rhinoplasty surgeon. Then when you start your rhinoplasty career, then first you choose your mentor, a teacher, a guru. The guru bina gyan nahi. So first you choose a teacher, and then you read one or two good books. I recommend Rolin Daniel. Rolin Daniel have the two book. One is the Rolin Daniel textbook, and another is the Rolin Daniel Atlas. So Rolin Daniel textbook is good for the beginner friends. And then another book, the Dissection Manual of the Dean Torumi. So these two book, I think you should read 2 or 3 times. So you should familiar with the terms and regarding the deformity and the basic techniques, and then you just watch the YouTube video regarding the surgery, and then attend the cadaver dissections course, and then hands-on surgical sessions. So in this way you start your rhinoplasty career. Now once you start your rhinoplasty career, then how you improve your results, how you become more and more learn. So I think I create the 5 steps. So when you follow these 5 steps, then you learn more and more regarding the rhinoplasty. So the step number 1, your patient selection. Your patient selection, that should be proper. So I think when you select the patient, then you know the concern of the patient. Either your patient concern is functional or cosmetic or both. Okay, and then the motivation of the patient. Your patient should be primarily motivated. If a patient has a gross deformity and he is not primarily motivated for surgery, you cannot satisfy the patient. So your patient, that should be primarily motivated. And the second, you should also know the comfort zone of yourself, comfort zone of the surgeon. Every surgeon know what is my comfort zone, but initially when you attend the cases like a gross deformity, because once you have a good result, then you build up your confidence. So we always focus on the patient, but you also know the comfort zone of the surgeon. When you attend a minor deformity initially, and then patient have the less satisfying, you have a more chance of the litigations. So this is the first step. Now the second step, that is the patient analysis. The patient analysis is very important. First, you hear the patient. What is the chief complaint of the patient? What is motto of the patient? And then you noted in your operative sheets, in your history, and what is your patient want. And then second, when you examine, then your notes should be you examine thoroughly from outside to the inner framework and the interior of the nose. Uh, when you examine the outside of the nose, because guys, you know that almost every Indian patient have a thick skin patient, and the patient want, whenever he remove the splint, then he need a big, good refined nose. So you explain the patient. When a patient have a thick skin patient, then it will take time to subside the edema. So you explain to the patient regarding the outcome of the result. So outer skin soft tissue envelope examination is important, and then the second important thing regarding the internal examination, that means in inner framework of the nose. I think in a rhinoplasty surgeon you have a sense in your mind, then what underlying part of the framework have the deformity. You have this sense, like this. Suppose this patient have a depression on the ala, that means you think this patient have a deformity in the lateral crus part. And suppose some patient have a concavity on the nasal bone, then you think the patient have the deformity in the in this nasal bone. So you have know that what underlying part of the nose have the deformity. And then third, interior examination of the nose. This is very important. So first you examine the nose endoscopically. So just because sometimes otherwise you miss the finding, like the posterior septum deviation, like the inferior turbinate condition, and sometimes the patient have a silent septal perforation. And you know the note of the patient after this COVID, the patient have the complaint of the anosmia. So you these all things you should properly documented, otherwise the patient blame on you. So you thorough examinations. I realize that my some plastic surgeon colleagues, they don't have the routine use of endoscope in the OPD, so sometimes they miss the findings. But I think you should proper examine and you make a complete exact diagnosis. So this is the second step. Now, if we move the third step, your sequential operative steps. You never jump from the one step to another step. So you have a set pattern in your mind regarding the operative steps. And it's the simple. How is the simple? Like first you infiltrate the nose, and then you open the nose properly, expose the nose properly, and the last step you close properly and taping properly. So these three steps, that is the same in each and every case in the rhinoplasty. But the some step like septum modifications, whatever the patient have the deformity in the septum, septum modification, and then the bony vault modifications by the different type of the combo of the different type of the osteotomies. Then if you come down the mid vault modifications and then the tip modifications. So these are the set pattern. And we follow in this patient. I create the 7 golden steps. We discuss later once we start the case. So your operative step that be sequential. This is the third step. Now, if you go in the fourth step, your outlook analysis. You know, for your outlook analysis, the two tools are the important. What is that? Number one, your photographs. You should have a high quality reproducible photographs, and your photograph that should be proper in the uniform background by the DSLR cameras, and then your distance in the photograph, distance with the background, distance with the camera, distance with the light source, and the pre-operative and the post-operative photograph, that all should be in the same. मेरा phone देख लेना उसको. That should be in the same. So you can judge, you can compare your pre-operative and the post-operative. Recently, we have a lot of Android phones and some lot of beginner friends. They click the picture by the Androids. This is the wrong methods. Okay, so there is a different class of the photography, how you take a photograph, but photograph that should be proper, and the photograph that should be properly documented in the PC, because once you know, sometimes the patient come after the 3 years, then and then you don't know where is the photo, so that you should be in the documented properly. And the second, regarding the outlook analysis, second tool is the operative sheets. Your operative sheets that should be properly in own handwriting, because after some time we forget what is, we add on and what we remove in this case. So you thoroughly all these things mentions in your operative worksheets, what you add on, what you remove, what you excise, so you compare of result. So this is the fourth step of improving. Now the last step, fifth step, what is that? That is the critics. That is the critics. So what is that critics? Critics means, like, sometimes, whenever a patient have a crooked nose, and after the removal of the splint, oh, patient is happy, but you are not happy. You think that this patient need little bit deviation in the root of the nose, and the tip is not good. This is the critics. So when you start the critics your own, okay, then this is the learning. So this is the most important step of learning. So how you improve your critics? Again, go back to your mentor, read the good books, watch the YouTube videos, attend the cadaver dissection course, and then hands-on surgical sessions. So this is the rhinoplasty cycle. This is the rhinoplasty cycle. So in the rhinoplasty cycle, once you do more and more cases, then you start then how you improve and become a good rhinoplasty surgeons, because and you never have a ego that you become a master in rhinoplasty. You learn in your mind, you just that you never become a master in this rhinoplasty. So this is the regarding how you start your rhinoplasty career and then how you improve your result. Now, uh, after this, we just discuss the photograph of this patient. Um, we explains regarding the photograph, because photographic analysis is very important for a successful rhinoplasty. Like like all ENT guys, we read the CT scan PNS for a sinus surgery, and before reading the sinus CT scan of the sinus, it's impossible to do the functional endoscopic sinus surgery. So before the analysis of the photograph, I think it's very difficult. Just so we just discuss regarding the photograph of the patient. For rhinoplasty analysis, usually we have the 6 standard views. Um, One is the frontal, two is the lateral view or the profile view, and two is the oblique view, and one is the basal view that usually we need for a standard analysis photography of the patient. And sometimes we need two more views. One is the helicopter view or the head neck text view, and another is the dynamic or the smiling view that usually we need, but they usually when sometimes when certain indications. So first, when you get the photograph, I think you should good have a good photograph. Then all photographs, all like in the head position of the patient, that should be in the Frankfurt horizontal plane, except the basal view. Rest of all photograph, then your position of the head of the patient, that should be in the Frankfurt horizontal plane. So the first this is the frontal view. So when you examine the frontal view, yeah, or any view, then you should know then what you want to examine in a photograph. First, you have in your mind, you have the photo, but you have to knowledge that what you want to evaluate in your photograph regarding this patient. Okay, and when you describe your photograph, then you should be systematic manner, like this the patient, this young female patient, in the frontal view, when we examine the frontal view, then from the top to bottom, then from the top to bottom, when you describe your patient, that in each and every view you have some 5 or 6 point you evaluate that. Like in the frontal view, you examine the symmetry of the nose, and then the dorsal aesthetic line regarding details, regarding the deviation of the nose, regarding the width of the bony base or the mid vault, and some details regarding the shape of the tip, regarding the ala base, regarding the ala and the columella relationship. So this is the simple 4 or 5 things you evaluate in the frontal view. So look that. So in this patient, this is the patient, have a young female patient. So from when we discuss from the top to bottom, then the first you examine the thickness of the skin. This is not typical thick skin patient, but yes, the skin quality is the good. And then first we check the symmetry of the nose. So symmetry of the nose itself and symmetry of the nose with the rest of the face. This is the both of. We always focus on the symmetry of the nose, but you never forget the symmetry of the face also, because sometimes the patient not notice before to the surgery, but after the surgery the things are noticed by the patient. So you notice the asymmetry of the face also. So how you just check the symmetry of the face, symmetry of the nose? Once you draw a line from the mid glabella to the mentone, then ideally the nose, this line that should bisect the bridge of the nose and the tip. So then you can say that the nose is symmetrical. Okay, you can say the nose is symmetrical. ये दूसरा बेसल भी को एक बार लगा दो. Yes. So the nose is symmetrical. इधर से आके लगा दो कोई. The nose is symmetrical. Now you check the deviation of the nose. Is there, if the dorsum is shifted from the midline either in the right side or left side, then you check the deviation of the nose. And if the dorsum is shifted from the either right side or left side, that is the deviated nose. But if your dorsum is deviated from the midline but not straight, is either a curve, either is a C-shaped or either is a S-shaped, that there is a crooked nose. That is the crooked nose. This is the difference between the crooked nose and the deviated nose. So you check the symmetry and any deviations and the dorsal aesthetic lines. So what is the dorsal aesthetic line? The curve unbroken line from the mid part of the eyebrow to the on that side tip defining point. So this dorsal aesthetic line, what depict the contour irregularities of the dorsum. So in this patient, this is little bit ill-defined dorsal aesthetic line. And if sometimes this dorsal aesthetic line have the X aggregation in the curving, that indicate either you have a over wide bony dorsum, and maybe you have a pinching of your mid vault. Okay. Then after the symmetry, after the deviation, after the dorsal aesthetic line, your width of your bony base and width of your like this, इधर से आगे लगा दो राजवीर, इधर से पीछे से आगे लगा दो, and then width of your mid vault. So ideally the node that should run between the grossly between the both of this medial canthus. So there is a relationship between this width of the bony base and this ala base width. Ideally, this width that should be 2/3 of this ala base width, and this ala base width that should be equal to the intercanthal distance. So in your patient, if this bony base width is more than 2/3 of this ala base width, then grossly you need the narrowing of the nose. You need the osteotomy, because there is a bias. There is a sometimes we confuse. We ask to the sister, this patient need the osteotomy, this patient need or not osteotomy. So it's the simple formula. You just check if there is a more than 2/3 of the ala base width, then definitely you need narrowing of your basically bony base. So in this patient, look that he have some little bit, not too much, and this patient doesn't have the concern regarding the width of the nose also. But if we examine in the photograph, and in this upper part, the patient some little bit over wide bony dorsum, and then if you come down, then this patient have some like just like narrowing of the mid vault, and it's just like appear as a pinching nose in this mid part. So then if you come down on the tip, then on the tip regarding the size. So look that the size of this tip, this is little bit bulbous tip. So the size of the tip, that is the little bit bulbous tip. So first we just the symmetry of the tip. Tip is symmetrical, but the shape of the tip is bulbous tip. And look that, and if we just see the close-up view of this one on the tip, then there is a the groove in the supraellar area. So I think once you examine the photograph, then you develop a sense in your mind. Then maybe why have this problem? Why we have this notch in the patient? So personally feel that maybe this patient have some abnormality regarding the lateral crus. So there is a swapping of this one, and this lateral crus maybe have the malposition, because ideally this have the lateral crest towards the lateral canthus, but I think in this patient that is towards the medial canthus. That's why we have this narrow area or the depression on this part. So maybe have the cephalic malpositions and the that we call the parenthesis deformity. So what is the parenthesis deformity? Parenthesis, that means some two curved line. These are two curved line on both sides. This side is the more, this side is the less. So that is the parenthesis deformity. Parenthesis, that means if you call in the Hindi the कोष्टक, जैसे हम कोष्टक लगाते हैं, just like to make a curved line, that is the parenthesis deformity. So like when the orientation of this lateral crus is changed, then this part of the LRM lost the support. Okay, so the patient develops. So maybe once we open that, then we have a second look. Maybe this patient have a parenthesis deformity and the cephalic malposition, and that's why the patient have some bulbous tip. Okay, then if you come down on the relationship of the ella and the relationship of the this columella. So ideally, for a good aesthetic pleasing tip, there is a relationship between the margin of the ella and this columella. Ideally, the columella should hang 2 to 4 mm. So that we call the gull in wing or gull in flight appearance. So in this patient, I think this columella, that is the overhanging columella, it appears there is a overhanging columella. And then all another important thing, we measure the ella base width in this frontal view. So in this frontal view, we measure this like the symmetry, like the deviation, dorsal aesthetic line, the width of the bony base and shape of the tip, symmetry of the tip, and the ella base width and ella columella relationship. Now, if you move on the another view, this is the profile view, or we can say the lateral view. So when you examine in the lateral view, the same top to bottom, there are 4 or 5 points. First, the radix detail. In this the radix detail, because due to the some medical legal purpose, I just cover this one. So once this the basically you can examine, I think this one, yeah, you focus this one, yeah, this one. So we just evaluate the details of the radix and nasofrontal angle area. Okay, so ideally for my beginner friends, the radix is the 9 to 14 mm, the depth of the radix. If the radix is less than this, then you have a shallow radix. And you know, when you have a shallow radix, then it changes the appearance of the nose. The nose appear the longer. On the other hand, if you have the deep radix, then you have a short nose. So in this patient, the radix is the shallow radix, so it appear a longer nose appearance. And we also measure the nasofrontal angle, the angle between the nasion glabella to the nasion, and then nasion to the tip defining point. That should be in the 115 to the 20. So we evaluate the nasofrontal angle area. Then if we come down, then is the dorsum of the node. So how you examine the dorsum in this profile view? If you draw a line from this nasion to the tip defining point, then ideally the dorsum fall 1 to 2 mm behind. If the dorsum have the more than this, then you need the reduction of the dorsum. And if the dorsum, like if you draw a line from nasion to the tip defining point, if have the more than, then that you need the reduction, and if you have the just more posterior, then you need the augmentations. So this is the on this patient have a huge axis part of the dorsum in the bony and the cartilaginous bump in this area. Then if you come down on the tip area, then you just examine regarding the projections and the rotations of the nose. So what is the projections? Projection is the distance by which the nose project from this face. So from this elafacial junction to the tip, this is the distance. So first you know that how you know that your patient have a over projected or under projected nose. So first you know what is the normal projections. So for my beginner friend, grossly the length of this columella from the base of columella to the tip, and from this base of columella or from subnasal to the upper lip, ideally this should be equal. This should be equal grossly. And ideally the nose projection that should be two-thirds of the nasal length. So first you know regarding this, and like this patient, I think if we compare this one, then this part is the more little bit over projected, and uh, the rotation we measure in the nasolabial angle between the base of the columella and upper lip. That ideally for a female patient that should be 95 to 115 and degree, and for a male patient that should be acute around the 90 degree. So this is the way then you examine regarding the projection and the rotation. There is one very important thing, that how look at this patient Ella and the columella relationship. If we examine, then it appear that this patient have a overhanging columella. But if someone asks that this patient have a retracted Ella, so how you differentiate that my patient have a retracted Ella or the overhanging columella? This is very important. So for my junior colleagues, then how you examine, if you draw a line, if you draw a line from the medial most part of your ala margin and the lateral most part of the ala margin like this, I again repeat, if you draw a line from the medial most part of the ala margin and then the lateral most part of the ala margins, if you draw a line and then another line from the mid part of the columella to like this, and if the distance of this is more than 2 then you have a ala retracted, and if you have the distance of this one, then you have a overhanging columella. This is the simple calculations. So you can judge that my patient correction of the ala retraction or correction of the overhanging columella. So this is very important finding. So these are the some things that we have to examine in the profile view. Then if you come down on the basal view, so ideally look that the nose in the basal view just is a isosceles triangle. What is the isosceles? Then when in a triangle, when two angles that are normal, that we say that is the isosceles triangle. So this is the isosceles triangle. So in this isosceles triangle, what we examine, one is the TC ratio. What is the TC ratio? Tip lobule and the columella ratio. Ideally, in this isosceles triangle, the tip and the columella ratio, uh, that is the tip lobule that should be one third, and the columella that should be two third. So it's the 2:1 ratio. In this patient, I think the ratio is good, but this columella part is the below the foot plate is flaring of the foot plate. So we examine the tip and the columella ratio, and then another we just regarding the nostril. So regarding the nostril, the size, regarding the shape and the orientation of the nostril. So look that the size of the both of the nostril is not equal. This is around the like the oval shape, and this is not the same of this one, and the shape is not normal, and the orientation is almost good. Ideal the orientation of the nostril towards the medially around the 45-degree angle. And then another that we examine, that is the ala base details and the ala margin details. So ideally your patient have a ala flaring and over wide ala base. We detail evaluate in this basal view. So this is the elafacial junctions. If the patient have a axis inter-alar width rather than the intercanthal distance, then you have a over wide ala base. And some this is the ala margin. If this ala margin is beyond the curvature of this ala is the beyond this ala facial junction, then that you say the ala flaring. So there is a two term ala flaring or ala base, over wide ala base. Suppose if you want to correction of this ala flaring, that means once you have a excessive concavity or convexity of this ala margin, then you reduce this part, you excise the ala base. Suppose on the another hand, you have excess this inter-alar width, then you excise this cylindrical sill part of the nose. So these things you have to know. So the normal anatomy is really important to detect the abnormal anatomy. Okay, and then this is the details that we usually we examine in the basal view. If you the come down like this is the helicopter view or like the head next text view, there is a new term that given by Dr. Kapil Agarwal, like the head neck text view. So in the head neck text view, we evaluate some better assess if a patient have a minor deviations and the details of the dorsum also. So you can better judge rather than a frontal view. And this is the I think this is the oblique view. So in oblique view, we confirm the finding of that frontal or the profile view, and you can better assess the individual side of the ala detail. Either is a contour irregularities or it is a orientation regularities, you can better judge and you can better judge the dorsum also. And when you click this oblique view, then I think that one side of the complete of the cheek that should be visible in your photograph, and other side that is the 1/4. So the Frankfurt horizontal positions and other side the cheek 1/4 that should be visible. So I think regarding the photographic analysis, all we confirm, and really 4 or 5 point you remember in your mind दिमाग में बिठा लो कि this should be we evaluate, and you just make a exact diagnosis, then how you proceed in your case, because this is the roadmap. Just like I already discussed that just like a CT scan during the face, your photographic analysis is very important and it's a very good habit. Then you just click photographs and you have the printout and you have in front of all these you just in your OT, so that you can meanwhile the surgery you can judge regarding your results. So I think second part that is the complete, and now we come to our surgical part. मेरी headlight देना. Someone have any questions regarding that, definitely you can ask. So I think we can learn each other more things. Give me the gloves. So my this patient, that is a 22-year-old male female patient, and the concern of this patient is particularly regarding the bump on the nose, and she also have the functionally problem complaint of the nasal blockage also. So she have the both regarding the functional and regarding the cosmetic. So in this patient, we just I think we follow the sequential operative steps, and just to make the simplification, the learning of the rhinoplasty steps, I create the 7 golden step of rhinoplasty that we say in the short the 7G step. So in the 7G step, I think the first, second, and the last step almost the same in each and every case. First, that is the infiltration, and the second is the opening of the nose and the exposure, and the last step that is the closing and the taping of the nose. Then they are the same. The third step that is the septum modifications, and the fourth bony bolt modification, and then the fifth that is the mid vault modifications, and then the six, the tip modifications. My each and every case that I follow these seven G step, and it's my advice to my beginner friend also. Then you should follow these seven sequential step in each and every case. So I already infiltrate, but there is a lot of time. So I first demonstrate the infiltrations in this case. I usually infiltrate this 2% xylocaine in already mixed the adrenaline in 30 ml vial, 1:1 lakh ratio. And I usually need the 5 ml syringe and this 26 gauge needle and 1.5-inch needle, that is the good needle, बड़ी needle देना. So again, for making the simple, understand the learning how you infiltrate in your patient, then I create a 5 steps for of the infiltrations. So needle नहीं है, needle लगाओ. लोकल देना मेरे को, लोकल देना, लोकल देना, लोकल देना, लोकल देना. ये क्या है आपको, सेलाइन है, डाइल्यूट सेलाइन है, बट लोकल भी देना बिकॉज काफी टाइम हो गया. सो the first step, the septum infiltrations, nasal speculum. So for septum, I usually use this needle, long needle, and the 5 ml syringe, and then I infiltrate. वो देना, packing forceps देना. So I infiltrate first in the septum. When you infiltrate in the septum, then it's the very important thing. You can infiltrate along the site of the incision, or you infiltrate in the anterior to the posterior. But when you infiltrate, then rather than the blanching, I think if you have a ballooning, then is a good sign of your infiltration, because it help in the hydrodissections. Like some renowned surgeon, they use infiltration only in the anterior part of the septum. According to that, once you get the plane, there is no need the infiltration the posterior side. But I think it's the better if you infiltrate anterior to the posterior in the entire septum. So on this infiltrate the cold saline. I usually infiltrate the cold saline just for the hydrodissections, and I think you can practice in your septum patient also by this cold saline for my beginner friends. Then how you infiltrate for the rhinoplasty. So this is the first step of the infiltration. Now the second step of the infiltration, एक दूसरी सीरीज में लोकल भी ले लो, दूसरी सीरीज में लोकल भी ले लो. तो the second step of the infiltration for the transcolumella incision. So look at how you, like this. First you hold your tip between the index finger and the thumb, and then from this tip defining point to the anterior nasal spine. But before to infiltrate, you just aspirate, and then like this. Okay, and then again between the tip defining point, between the tip defining point. ये लोकल है ना, थोड़ा सा ही दे देना बिकॉज काफी टाइम हो गया. So between the tip defining point to the anterior nasal spine, and then between the tip defining point like this, and then in this vestibular skin. So this is the second step of the infiltration. Now third step of the infiltration for the marginal incision. Give me the gauge piece. And after the infiltration of this between your index finger and thumb, you just massage it for the dispersion of your local infiltrations. So this is the good habit. Now the third step for the marginal incision. So look that you use this small wide prong retractor like this, and just in the alar margin, and you evert like this, and along your margin of the lateral crust, you just infiltrate in the lateral most part, and then in the mid part, and then in this soft triangle area, in this soft triangle area, like this. Never infiltrate too much, otherwise your outline that should be disturbed. So 0.2 ml and 0.3 ml in one infiltration, that is enough. बड़ी वाली needle लगाना. So this is the third step of the infiltration. Now the fourth step of the infiltration, that is the for the dorsal degloving. So where you engage this needle. This is the important thing. So you just use this nasal speculum. This is your upper lateral cartilage. I think this is your upper lateral cartilage. Lateral nasal wall also. So again, just like you lift up this one, or you can use the nasal speculum, and you identify the anterior end of the inferior turbinate nasal speculum. So this is my the anterior end of the head of the inferior turbinate. I show you, this is the anterior end of the inferior turbinate. So just lateral to the anterior end of the inferior turbinate, I pass this needle and along the lateral nasal wall, and then you can appreciate this is my needle. This is my needle. So intercanthal line, that is the upper limit, and then we infiltrate along this like this. So this is the last step on this side also, along the lateral nasal wall. So on both sides on the lateral nasal wall, we infiltrate. So these we complete the 5 step of the infiltration. So I think for my beginner friend, then if you develop the practice just in this 5 way simple step, then because the infiltration is very important part. So after the infiltrations, we just little bit discuss regarding the important surgical landmark in the brief, regarding the bony vault, regarding the mid vault, and regarding the tip lobule. So like this is the entire nose pyramid. So this entire basically the nose pyramid, basically this consists by 3 pairs structures, like 1 pair of the nasal bone, and then 1 pair of the upper lateral cartilage, and then 1 pair of the lower lateral or LR cartilage. So this 1 pair of nasal bone have the some important 6 important attachment and some important surgical landmark regarding the glabella, that is the midpoint between the eyebrows, and then after the glabella, then that is the radix. So radix is the distance between the frontonasal sutures. So this is the root of the nose. So the deepest point in this frontonasal suture, that is the nasion. And then if you the come down, this is the rhinion, this is the osteocartilaginous junctions. So regarding the rhinion, the 2 things are the important. One, regarding the skin thickness. If you compare the skin thickness, then the skin thickness in the nasofrontal suture area is the thickest, and in this rhinion is the thinnest. If you come down, then the skin is highly variable due to the sebaceous content in the tip area. And another important thing, we have a very important area at the rhinion area, that is the keystone area. We have the central keystone area, and another is the lateral keystone area. So what is the keystone area? Keystone area is the basically junction of the all 4 structure, like nasal bone and the upper lateral cartilage and the bony septum and the cartilaginous septum. But in this central part, when we open the nose, then we see in the central part, like look that this is basically the distal part of the nasal bone. This is my upper lateral cartilage. So like this on this distal part of the nasal bone, this upper lateral cartilage have like this. So this overlapping is maximum in this central part of keystone area. So that's why the this upper lateral cartilage get maximum support from this area. So that's why we always maintain integrity of this area. When we go the laterally, ये ऐसे चला देना यार. When we go the laterally, then this overlapping is reduced. So these are the important regarding the bony vault. And then if we come back on the mid vault, when we open the nose, when we see that this upper lateral, triangular upper lateral cartilage have a 4 important attach medially with the septum, that have a, and laterally in this wedge of like upper part of this piriform aperture, and superiorly with distal part of the nasal bone, and inferiorly with the uh, cephalic part of the lateral crus. So on all, we have very all 4 important area. One is like a keystone area, and inferiorly we have the scroll area, medially we have the internal nasal wall, and laterally the keystone area, this Webster triangle area. So once we open the nose, then we discuss in the detail, and then if you come down the this tip lobule, for a normal ENT surgeon, this entire is the tip. But for a rhinoplasty surgeon, The tip is this anteriorly projecting area, central part, that is the tip. So on either side of this tip, because we have the in this tip lobule we have the four subunit. In this central part, this is the tip. On either side we have this ala lobule, and then in the mid part this is the columella, and between the columella and this we have this nostril cavity. So you have to know regarding the four normal anatomy, then you judge about the abnormal anatomy. So in this tip area, we have two light reflecting area, that is the tip defining point on either side, and where the tip end and the dorsum end. This is the supratip brach. When and inferiorly where the tip end and the columella start, that is the infratip brach. Okay, and then this is the ala lobule, and very important thing, this ala lobule doesn't have the sound like the cartilaginous support. So this free part, this is the ala margin, and the base were attached with the cheek. This is the ala base. This is the ala base, and this vertical column like structure, that is the columella. So this part, this is the foot plate of the columella, and this is the pillar of the columella. And then this part that medial to this one and lateral to this columella and medial, this is the nostril. So this nostril have very important on the apex of the nostril. We have a very important area. This is the triangular, soft triangular. So once we open the nose, when we discuss, this is the soft triangle, and inferiorly this posterior cylindrical area, this is the seal of the nose. So these are the important landmark regarding the nose. So you have to know, so you can identify what underlying patient have the deformity. Now we move to the second G step, second golden step. Then how you open the nose. इनको clean कर दो थोड़ा सा यार. Meanwhile, Dr. Will, if like some moderator is join, then एक बार बता देना, ठीक है ना? If someone join, then so we can welcome and introduce them. So now we move the second step. That how you open the nose, exposure of the nose. My mentor, Dr. Satish Jain, he always told that in each and every surgery, you never compromise in the exposure. Never compromise in the exposure. So you should have a systematic manner how you expose. So for the exposure of the nose in this open rhinoplasty, usually we use the two incision. One is the transcolumella incision and another is the marginal incision. Okay. So I attend a lot of national and international meeting. Particularly my beginner friend, they ask regarding this opening of the nose, and they have the three questions in their mind. Huh? Yeah, Kapil Agwa. Okay. Dr. Kapil, boss, I think he joined. Okay, okay. Welcome, Dr. Kapil. And Dr. Kapil boss is a very good teacher. I always learn something whenever I meet the new things regarding recently in the RCCon meeting in Dr. Gaisas at the Mumbai. So, okay, we can discuss with them. Yeah. Good morning, Dr. Kapil boss.
Good morning. Good morning.
Okay, welcome boss, and thank you for joining.
Thank you.
Okay.
I've just joined actually half an hour of 45
Oh,
minutes.
thank you. So the second step, that is how you open your nose. So like three questions have my beginner friend, they confuse that three questions. Then first, which incision I use first? What is the sequence of the incision between the transcolumella and the marginal? And the second confusion in their mind, then which incision is good? Either the inverted V incision, either the W incision, either the like the other incision. So, and the third, what is the exact site of the incision? So I think the first we clear the three questions, that is good for my beginner friends. Then number one, the sequence regarding the incision, either the transcolumella incision and the marginal incision. So friends, it's hardly matter either you use the transcolumella incision first or the like the marginal incision. Some renowned surgeon like Dr. Hossam Fodal, Dr. Virendra Gaisas also, I saw in the meeting, he used the marginal incision first. So how you more comfort? I personally use transcolumella incision, and my reason behind that one, why I use the transcolumella, because the rest of the incision is under my visions. Otherwise, you can use according to your comfort. So this is the first question clear. Now the second questions that which type of the incision is good, either the inverted V incision or stair step incision. So there is a different type of the incision, but mostly incision used are the either the inverted V incision or the stair step incision. But the logic, we never use the straight incision. We use the incision in the broken line in the zigzag manner. Why? Because we increase the length of the incision and you have a less chance of the scar tendency. I personally prefer the inverted V incisions. Why I use the inverted V incision? I personally feel because sometimes suppose someone use like the stair step incision like this, then the problem in the stair step incision, because this upper limb just nearby the soft triangle, sometimes the patient have a asymmetrical scar. So I personally use the inverted V incision, so that is not problem in this uh, stair step incision. But again, it's a matter of confidence. It's a matter of experience. Still, some renowned surgeon in India also they use the stair step incision. I personally use this inverted V incision. Then second question is clear, and now the third questions, the site of the incision. Really, this is the most important thing. Your site of the incision, that should be exact on the mid narrowest part of the columella. But the question again, why is the mid narrowest part of the columella? Because in the mid narrowest part of the columella, the margin of the medial crust is more approximated with this skin, columella skin. So once during the healing period, the patient have a less chance of the scar tendency. So I think three questions we cleared regarding the incision. So then how you make the exact the mid part of the columella? The common mistake done by the beginners, they measure from this to this. This is the wrong method. Okay, is there any problem?
So there are some questions from Rita, but we unput them later.
Yeah, we can ask. We can ask. We can ask. What is the questions? What is that questions? Definitely, because this webinar on for learning, not for only the demonstrations. Learning. You clear all queries. I think because if you have the query, definitely you can ask. What is the questions? So we discussed then how we measure the mid narrowest part of the columella. So look that for my beginner friends, this is the apex of this nostril. So you just mark the apex of the nostril like this, and this is the base of the columella. So now you just point the mark the mid part of this one. So this is the mid part of the columella. Like just you make a single dot and like this and like this. This is the usual uh, incision. Sometimes when you want to the deep project of the nose little bit, then you can use the higher. And sometimes particularly when you have it like this columella, like you have it this very short columella, in that case you use like the incision like in a V to Y manner for increasing the length of the your columella skin, particularly in a binder cases, but it's only very limited cases. Hello.
You can ask.
If someone have the question,
Hello.
hello, yes, I hear you.
Hello, sir. This is question regarding the infiltration.
Yeah,
Have you infiltrated with cold saline throughout the nose?
yeah. I first infiltrate the local infiltration 2% xylocaine, but meanwhile, when during the preparation or something, sometimes the effect has gone. So I usually in my practice, the all 5 step I infiltrate cold saline also. So the advantage of that is the better some hemostasis help also, and for the hydro dissections also, and there is no harmful effect of the cold saline. So I think last I think the 1 year almost in each and every case I use the cold saline, and I just learned this technique from Dr. Miguel from the Portuguese. So he doing since last 25 year this cold saline infiltration. So I usually in this case also I infiltrate.
Okay.
So now we just mark this inverted V incision, and ideally the distance between these two dots is not more than 3 millimeter, and the marking habit is the good habit. You always develop the marking habit. So once you mark the things, then you know, you learn then in which part of inner framework your patient have the deformity. And once you have a sense in your mind, and then once you open the notes and you check that thing, so then you mark like this, like in this patient, like look that like this is the lateral crest, like this is the lateral crest. So the direction of the lateral crest is towards the medial canthus. So once we open the thing, I usually mark. So marking habits, the good habits. Now then the this. So this incision is just like a W incision, and then on either side like this, few millimeter behind, 1 or 2 millimeter behind, and then now how you make the incision, because this is a big fear to my beginner surgeons, and it's the only fear of the patient also regarding the incision. So first you hold firmly your index, your tip between the tip lobule between the index finger and the thumb, just like this. थोड़ा सा मेरे को ये इंसिजन ऊपर लगाना है, थोड़ा सा जस्ट लाइक ऊपर लगाना है, because I usually mark my incision before to the infiltration. That is a good habit, because sometimes after the infiltration little bit change your contour. So uh, I think if before to infiltrate, if you mark, that is a good habit. Just little bit higher, just like this, just like this. Yes. Now you hold this one like this, and then I usually use this 11 number blade, and look at how you hold this one, just like a pen holding positions, and your knife that should be perpendicular. If you are not perpendicular, you bevel your margin, and if you bevel your margin, then you develop the trapdoor deformity, overlapping of the margin. So like this. मेरी headlight on कर देना. Yes. So just like we make the incision like this, just this is a stab incision, just like this, okay, and then by the 15 number blade. So again, you hold like the same in this manner, and then if you go like this is the wrong method, because sometime accidentally you injure this ala margin. So I think if you go lateral to medial, that is the good. Suction on कर लो, irrigation continue कर लो, suction on कर लो, and then just like this, and again like this, and on just few millimeter behind like this, and on this side also. Yes. So you just mark first and then make the incision. My incision is complete. Then the further step that, yes. Now you need this simple sharp scissor. This is a very good scissor of the Medicone. So then again you hold it firmly and give good counter pressure like this, because otherwise there is little bit oozing like this. So once you like pull like this, then you don't have the bleeding, and then you pass from this side to the another side like this. And if you feel the resistance, then you go from the ana, because sometimes otherwise accidentally you have the damage, or you create a false passage. So from ipsilateral to the contralateral side, just you pass like this. And now you complete your incision. Now you have the support of the seizure. Now, and you stay superficial to the margin of the medial crust. And like this, huh? What is the question?
So it's from Dr. Pooja Suyal from Uttaranchal.
Yeah.
What if scarring is present in the columella or for revision cases?
What means that? What you say?
What if scarring is present in the columella or
Yeah.
for revision cases?
Yeah, for revision cases, first important thing, then when you revise your case, if your case is, I think, is the early, or I think sometimes if your case then is a past, then more than 1 year and 1.5 year, and if you have the scarring, then first I think you properly the massage that incision site to ask the patient once you come, and then you make the incision if in a proper manner. I think if the patient have earlier the inverted V incision, I think in the same site you can apply. And Dr. Kapil Agarwal boss, what is your opinion regarding that? If a patient have a earlier scar, and then what is your expert opinion for that?
It
Kapil
doesn't
boss.
matter actually. It doesn't matter.
Yes,
Whichever kind of incision somebody has taken earlier.
yes.
Yeah, you can take the same incision.
Same incision,
Same
exactly.
incision.
So I think you should go according to the same incision. It's hardly matter. But if yeah, the issue we are hard tissue, then you ask the patient to massage before to that. That is a good practice. So now we have a support behind this one, and then we complete this incision like this. And look that this is the vessels, this is the columellar vessels. So sometimes we have some little bit oozing. So we complete this incision. This columellar vessels is the branch of the superior labial artery that is itself a branch of the facial artery system. So you also know the regarding the blood supply of the nose also. Now we complete the transcolumellar incision. Now, what instrument you need the further? You need these two instrument. These two instrument, one is the single look and this is the small white double prong retractor. So you have
There's a question from
yeah,
Dr. Ritu Sheth, Maharashtra.
yeah.
What is the lowest age for rhinoplasty?
Yeah. What is the lowest stage of the rhinoplasty? I think in this scenario, if your patient have a absolute nasal blockage, I think I do the rhinoplasty in a 8 year patient also. But there are some important thing like you never disturb some important area of the septum. Meanwhile, the rhinoplasty, because you just correct the functional part. When you correct the functional part, there are some vital site on the nose, so you never disturb that. But you can do, I think if a patient doesn't have the functional problem, then you can wait in the 14 year or the 15 year. But if your patient have a absolute nasal blockage, then you can do in the pediatric age. So the two advantage, one advantage, the patient once he I think the 18 or 19, then he customize for that his nose. So it's depend then what patient have the problem. So now we need these two instrument for this like this. Each like इसको ऐसे पकड़ो, बीच में ऐसे पकड़ो. Now this is the situation. So now first you identify the margin of the medial crust. How you identify the first you secure the margin of the medial crust. So I hold this sharp scissor just as a pen holding position, and it's a simple method. This is my medial right side of the margin of the medial crust. So first you secure, this is my right side of the margin of the medial crust, and now this is my margin of the left side of the medial crust. So first you secure the margin of the medial crust like this, like this. Sometimes when you pass a seizure, sometimes when you weak medial crust, and sometimes you injury of the medial crust, never panic, never panic. You थोड़ा सा नीचे कर दो इसको. You never panic. In the last, you can suture that injury by 6 O vicryl rapid or 6 O vicryl Prolene sutures. You never panic. So it's the because in the beginning sometimes you have the injury. So now for further, just like you just use इसको ऐसे लगाओ. we proceed the further assay. So the things are now visible. So I just spread it and cut it for further dissections like this. Just you follow along your margin of this one like this. In the soft triangle area, you use that you have never injury because is otherwise you have the badly nose letter. So just you spread it and cut it, spread it and cut it like this along the margin of the lateral crust. So this is the margin of the lateral crust. You can appreciate very well. For my beginner friends, then you can mark also this is the margin of the medial crust. So you just move along that, and your direction of the seizure is not like this towards lateral canthus. Your direction of seizures anterior inferior directions. Because this is the common mistake. Otherwise, when we do the like that, then we create a rim incisions. You never have a rim incision. So like this, you just spread it and cut it, spread it and cut it like this, and not the big chunk of the tissues. Now on this side, but again the question that what is my lateral limit of marginal incision? So the lateral limit of your marginal incision that you should expose at least two-thirds of your lateral crust. Again, just you follow. This is the advantage of the sequence. Once you use first this transcolumella incision, then everything is in front of you. And the counter pressure by this finger is important. So just like, yes, just we separate it and cut it, spread it and cut it. इसको थोड़ा सा ऐसे लगाओ. Yes. So this is the way. Then again, just like spread it and cut it, because once sometimes you have the malposition of the deformity of the lateral crust, then you use very judiciously. So now my transcolumella incision and my marginal incision that I complete. Next, I want to expose the lateral crust. So then I use these two or three instrument. This is small. This is wide double prong retractor. This is the wide. This is the small. We use classically the 3-point traction technique. So one use like this. You just, and then you invert like this. Yes, and then इसमें लगाओ. Yes, इसमें लगाओ. So counter traction is very important. Counter traction is very important. यहाँ लगाओ. Yes. So like this. And then another one small wide double prong retractor like this. ये ऐसे लगाओ. ये यहाँ पे लगाओ. Yes. So now first you get the right plane of the dissection, because it's a important step. Then what is my plane of dissections? My plane of the dissection in this case, that is the suprapericondial. So first I just create a tunnel for getting the ideal plane. So just I cut these tissues just little bit, because my plane of the dissection in this case, that is the suprapericondial. Uh, all Western book they mention the subpericondial plane, but in Indian scenario we have a thick skin patient, so then you use the suprapericondial, otherwise you weak your lateral crust. So look that I usually use this is Kakir periostem elevator. This is a good instrument. So I separate like this, and you have a very good plane now. You enjoy your surgery. There is no bleeding. Some rhinoplasty surgeon, the plane of the dissection, they like the Vitali, sometimes they use the supra smash the dissection, because he used this smash layer for reconstruction also. But I usually use the subpericondial. ये मेरा ये हटा देना चश्मा. मेरा चश्मा हटा देना. एक मिनट चश्मा हटा देना. Yes. Yes. So now again, just first you create the tunnel. Yes. And then You just expose your complete lateral crust. Now in front of us, we have this important structure. So this important structure, that is the a dermocartilaginous ligament. So this important structure, लगा देना यार चश्मा उसको बोलना, uh, have the two types of the fiber. One is the vertical fiber and one is the horizontal fiber. So by the vertical fiber, this structure connect with this rest of soft tissue envelope. So it's ligament of the pitangui. So we cut it, and also have the transverse fiber that connect the cephalic part of this lateral crust. So this is one of a minor tip support mechanism, and recently the old books mention it as one of a major tip support mechanism. So we cut it, we separate it, and the cut it like this, like this. So these are the transverse fiber. They connect this cephalic part of the lateral crust. So this is the important dermocartilaginous ligament. In the Western, in the rhinoplasty scenario, they preserve it because they have a concept of the supratip brake area. In Indian patients, we don't have the supratip brake concept, so we usually not bother for. But it's again depend on what patient you have. So now we just move further. You can use the scissor or you can use this elevator, just like swap, and again in the suprapericordial manner. So you have a very good plane of the dissection. There is no bleeding. You can enjoy your surgery just like. But the important thing, this instrument, the position of this instrument, if you leave it like this, then you have the oozing. So you have the counter traction like this. You change the position of this instrument. Just go again like the nearer to this one and just like lift up like this. So you find a net like structure. Then you again swap it like this, like this. So I expose my mid vault and then I expose my bony vault also. So again the question, then how much exposed laterally is also the important. So if your patient have a augmentation rhinoplasty, then you expose according to that. So your graph that snugly fit. But if you have a crooked nose and you want the rhino sculpture, then you expose laterally both sides properly for rhino sculpture. So ideally 1 centimeter either side you should expose both sides. So I expose my, and the upper limit of the exposure, that is the intercanthal line. This is the upper limit of the exposure. थोड़ा सा हाँ, this is the upper limit of the exposure. So ऑफ रिच देना मेरे को, ऑफ रिच देना, ऑफ रिच देना. Dr. Kapil Bose, any comment regarding the exposure of the dorsum?
Yeah, you have done very nice dissection, man. Very clean and nice dissection.
Thank you, boss. So I think my beginner friend, because you clear your all query of your mind, because sometimes we have a lot of query in our mind that how much we go the laterally. Uh, so according to the case, according we have exposure. So we expose the entire the dorsums and the lateral crest nerves. Now we move for exposure of the septum. So we use this self-retaining. I have this self-returning retractor. It's a very good retractor by the, I think by the Najim Circus. So this is the self-retaining. Look that how Mukesh isko lagao. So there is no need to the hold by one person, just to this soft tissue envelope by a retractor. So like this. So now your entire things is under vision. कोल्ड सेलाइन का देना दूसरा. So we expose the lateral crust, we expose the mid vault, we expose the bony vault. Now we want to expose the septum. So again, how you expose the septum is very important. So then you need these two forceps. ये दोनों दिया. I think you can buy these two. This is a very good key instrument and for cartilage holding forceps. So then you just hold your lateral crus like this, just in antero inferior direction like this. Like this is the way. This is the way. But once you hold this one, then you lift up like this and you find this net like structure. And then your dissection is easy. But if you do like this, then it's very difficult. So, like you hold, Mukesh, pakado isko. So, then again, you use this sharp scissor and then just like इसको clean करो. ये bleeding क्यों हो रहा है? बस. So just this is the interdermal ligament. This ligament is the interdermal ligament. So this ligament the connect the dome part of the intermediate crust. So we cut it. We cut it. We cut it. These are the some disadvantage of open rhinoplasty. Then we damage some of tip support mechanisms. So that's why we recreate it all these things again. Then we again spread it and cut it, spread it and cut it like this, and then we cut it like this. And then now you hold just nearer to this. Yes, पहले हमने यूं पकड़ा like now you this like this. So एक पर cautery देना. You have some bleeding? Oh, it's okay. It's okay. So look that the things are how change. Once we go near to them, you find something. You have this glimpse of this one. So this is the septum. This is the septum. So when you how you hold your instrument, the things are changed. Now just we separate these tissues and you identify the anterior septal angle area. So you have the sense in your mind, then what you want to identify, what you are doing. Hold. So I want to identify my anterior septal angle area. Once you identify the anterior septal angle area, then you the rest. थोड़ा सा आराम से कम फोर्स लगाओ है ना. So then this is my perichondrium on the, yes, so I just cut it. Yes. Now you can use now the sharp scissor, you can use now the periostem elevator. इसका फाइन फोकस ठीक है ना, देख लेना, राजवीर को बोलना ठीक है. मेरे को पता नहीं लगा फाइन फोकस ठीक है कि नहीं, वीटॉम का चेक कर लेना बोले. So then I usually use this sharp scissor. This is a sharp scissor and I usually use this is the pen holding positions. I learned this technique by my mentor Dr. Sandeep Paun. So this is the pen holding positions and then just I degloving this mucopericondium in the near to the anterior septal angle area like this just, and then on another side also, yes. So I think I feel that this is the one of the most difficult step in the rhinoplasty, because sometimes in a pediatric rhinoplasty or sometime in a revision case, secondary case, or sometime in a crooked case, it's very difficult to identify the plane of septum degloving. So I think sometimes, suppose if you have a tear on the one side, then you never lose your patience. You just move, you move on another side. And sometimes if your patient have a post septoplasty cases, so in that case, you just try to find the plane in the dorsal most part of the septum, because the dorsal most part of the septum, the mucopericondium is lessly adherent. So like in this part, you just can separate. Now, I separate both sides, my mucopericondium. Now, I assure that I'm actually in the normal plane or not. So, give me the 15 number blade. because your plane of dissection, that is the subpericondial. Some Western rhinoplasty surgeon like the Joseph Carlos, he used the suprapericondial dissections in a sub few millimeter behind the septum. I asked what is the logic behind then. Then he told me that just for the better blood supply of the graft and better survival of the graft. So that is the theory. But we just usually thus degloving the mucopericondium in the subperiosteal manner. So just like we scrape just like this. So just we assure either we are in the right plane or the not. थोड़ा टेबल ऊपर करना है भाई मेरे को टेबल ऊपर में कर रहा हूँ और विटोम की एक बार सेटिंग देख लेना एक बार so now then I just check look that so this is the difference this is my actual plane of the dissection I can lift it in this also. But look that the color of this field is different. So now this is the actual subpericondial plane. Look that this is the little bit reddish, but this is the actual the white plane. So in this way, if you are in the right plane, there is no bleeding at all, and you can enjoy your surgery. So on this side also, I just assure either I'm in the right plane or the not. So just 15 number bleed. These are the small things in the rhinoplasty that your things make the easy. So I I check. So look that this is my actual plane of the dissections. This is my actually plane of the dissections. Now yeah, I have a very good plane. Okay, on both sides I have now. How you proceed further? Uh, if you are a renowned rhinoplasty surgeons like Dr. Kapil, Dr. Desas, for you there is no problem. But I think for my beginner friends, I usually recommend first you degloving your mucopericondium on this pocket on under surface of the upper lateral cartilage. Look that uh, you can appreciate this is my periostem elevator. So what I am doing, I just separate this mucopericondium on under surface of this upper lateral on this side also on this side also section karo on this side also yes. So the advantage of that once I deglowing my mucopericondial pocket properly on under surface, then I separate my upper lateral and the septum. So I have the good region uh, for my rest of the exposure. So by the blade, I remove the upper lateral and the septum like this, like this, like this. Suppose you separate the upper lateral and the septum and you have a lot of bleeding, that it means you are in the not in the right plane. Maybe your mucopericondium is not properly degloving. So you remember these things. Saline pass भी देते जाओ बीच बीच में भूल गए क्या and now on this side इसको पकड़ो यहाँ से if you are in the right plane then you can enjoy your surgery. Yes, so yeah, we just separate the right side of the upper lateral with the septum. Yes. So now the things, everything in front of you. So clean karo, bilkul. Now we have the further sequence how you degloving your mucopericondium. So I think we have this sequence just like a in like cross manner. So I usually recommend first from the anterior superior direction and then in the posterior superior direction and then in the posterior inferior direction and then in the posterior superior direction and then in the last in the anterior inferior directions. So this is the sequence of degloving of your mucopericondium. So I just degloving this posterior inferior like this, and then like this, and in the last anterior inferior. Why in the last in the anterior inferior? Because in the anterior inferior this mucopericardium is very densely adherent with the maxillary crest area. So I think if you follow this sequence, that is a good. This is the suction periosteum elevator, that if you have a bleeding, then you can use this one also. So like this, because if you are the right plane, is called counter traction is again important, and you hold always septum with the cartilage holding forceps, that is, otherwise you have a tear, you have a injury. And then it's there very easy to degloving your mucopericardium with the rest of the septum. So now first from the posterior inferior, then posterior superior, and then in the anterior inferior like this. Show me, मेरे को अभी एंडोस्कोप लगाना, एंडोस्कोप लगाना, एंडोस्कोप लगाना, ठीक है. So now, so if you are in the right plane, there is no bleeding. Otherwise, we have a lot of struggle over the bleeding. So we just show the endoscopic picture. Endoscope लगाना. Give the endoscopic picture. Yes. No. Savlon देना. Give me the Savlon. Give me the Savlon. Phelon पहले क्यों नहीं रखा आपने? Savlon देना. So we can just check the posterior part of the septum, because this is the disadvantage when we do the septum work, then nobody can see the properly. So एक मिनट इसको क्लीन करो. सक्शन पेरियोस्टियम देना. So now फाइन फोकस करना कैमरे का, क्लीन नहीं है कैमरा. एक मिनट. Now is good. Now is good. So now this is the right side. This is the right side. This is the right side. कोई बात नहीं, कोई बात नहीं. So this is my posterior part of the septum, and the septum is deviated on this side. And if you just go on the posterior part, then you just, this is the bony part of the septum. This is the bony part of the septum. So you can see the, just like this, with the separate like this. This is the PP plate. This is the warmer part of, this is the rostrum, because septum anatomy is also very important. Look that. So this is the inferior part. So you can see the entire septum. So till the floor we expose properly. Yes. And this is the floor right side. Now we move on the another side. Now we move on the another side. This is the left side of septum. We have this spur on the junction. So just we negotiate gently, because you have a chance of the tear. So you just move gently, and then this is the posterior part. So you do your work gently, If sometimes one side tear, there is no problem, but I think you should try to develop the habit there is no tear on both sides, because septal perforation is a big problem. So look, this is the PP plate. Now I lift up entirely. Yes. So this is my spar. एक बार और क्लीन करो. Yes. 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 ये लगाओ ऊपर वापस वीटो लगाओ. So the exposure part after the infiltration, the second G step that is complete. So before to move just little bit with discussion regarding the interior anatomy of for my just in the brief for my beginner friends. लगाओ आया उसमें ठीक है. Yes. सीधा करो ठीक है. Give me the one instrument. So like we before to the open the nose, we discussed like this nose pyramid roof consists basically by the three pairs, one pair of the nasal bone and then one pair of the upper lateral and one pair of the lower lateral cartilage. And on underside, top to bottom, we have the three part of the septum like the bony septum, cartilaginous septum and the membranous septum. So basically, it's the house of septum that consists by a three pair of structure. कोई instrument देना.
Dr.
So,
Sorry,
yes.
many doctor came late. Can you explain the deformity and the
Yeah. Yes. Yes. So this patient basically is a 22-year-old female have complaint of the regarding breathing of the nose and regarding the cosmetic look of the patient. So regarding the breathings, he have right side of the nasal blockage, and regarding the cosmetic look, she have a bump on the nose, and she have a complaint that my nose is too projected on my face. So these two problem regarding cosmetic look of the patient and definitely have the blockage. So this problem before to when he consult me, then he have these two problem. So we open the nose and then we confirm all these finding. So this is the nasal bone on the both sides. This is the nasal bone on the both sides, and these nasal bone have the six important attachment. Just I describe in the brief. On the superior laterally, we have the lacrimal bone, and the inferior laterally we have this ascending process of the maxilla, and then superiorly we have the nasal process of the frontal bone, and inferiorly we have the attachment with this upper lateral cartilage. And if you come down on this mid vault, then this mid vault basically consists by a pair of upper lateral. So this upper lateral, इधर दिखाओ. This upper lateral is a triangular cartilage. Look there. This is the upper lateral. This is the upper lateral. So this upper lateral have the four important attachment. Medially, it attaches with this septum, cartilaginous septum. So this attachment have a important configurations at the 15 degree. So this is the nasal wall area. This consists the nasal wall area. So we always maintain the integrity of this nasal wall area. And if you go the laterally, then this upper lateral doesn't have the sound attachment. This attaches with the lowermost part of the piriform aperture. That area where this cartilage is attached, we call that is the Webster triangle area. So we always try to preserve during the lateral osteotomy this Webster triangle area. Why? Because sometimes if we injure this Webster triangle area, then this lateral part of the upper lateral cartilage is just like medialized like this. And because on the same side, the head of the inferior turbinate, this is the head of the inferior turbinate is also attached. So the head of the inferior turbinate, this head of the inferior turbinate is also medialized. So consequently, the patient develop the breathing problem. So this is the second important area that relate with this upper lateral cartilage with my for my beginner friend, and then superiorly it attaches with this distal part of the nasal bone. ऐसे पकड़ो बेटा इसको. This distal part of the nasal bone like this. ये इसके अंदर गया हुआ है नीचे. This is on under surface of the distal part of the nasal bone, and this have a overlapping. So this overlapping is maximum in this central area. That is the central keystone area. And once we move laterally, then this overlapping is reduced. In this area, we have around the 14 mm overlapping. But if you come the laterally, then the overlapping is reduced. That is the lateral keystone area. But this entire upper lateral cartilage have the maximum support from this area. Sometimes if you injure this area, then this upper lateral cartilage is inferior-medially collapse, and the patient develop the inverted V deformity. So this is the important attachment. Now, if you come down, then this is the lower part of this upper lateral cartilage. Okay, this is the lower part of, and this is the cephalic
Dr.
margin.
Sunil,
Sir. Yes,
Dr.
boss.
Sunil. Yeah,
Yes, yes.
please clean the area with the
Okay.
saline. It is
Yeah,
looking
saline देना.
very.
Yes,
Yeah.
yes. I just clean करता हूँ boss. Yes, clean करो. Clean करो. And साफ गोज पीस देना. साफ गोज पीस देना. साफ गोज पीस देना. Now I think better.
Yeah. It's nice.
Okay.
Nice now.
Yes,
Yeah.
yes. साफ गोज पीस दो भैया. So
Now it's contrast.
yeah. Yo. So now look that when I pull it, then you have this structure. This marker देना. You have this structure. And this is the whole. मुकेश कहाँ गया बोला उसको? So this is the structure. This is the structure. So when I left it, look that this is the overlapping. This is the overlapping between this distal part of the upper lateral cartilage and the cephalic part of the upper. This is lateral crus. So this is called the scroll area, and it is an important tip support, major tip support mechanism, because the tip have the three important tip support mechanism major. One is the size, shape, and resilience of this entire cartilage. What is the resilience? When we lift it and we leave it, then again in the same position. This is the resilience. And second, that is the scroll area. What is the scroll area for my junior friends? This is the overlapping. This is the overlapping between the distal part, lower part of the upper lateral cartilage, and this cephalic margin of the lateral crus. This is around the 15 mm area. That is the scroll area. Now, so we have this four internal nasal wall area, Webster triangle area, keystone area, and this scroll area. That is the important area that is related with this upper lateral cartilage. So it's a very important cartilage. It's just Dr. Pawan always told that it acts as a subserving cartilage. So we always maintain all the support surrounding this upper lateral cartilage. Now, if you come down with a pair of, this is the lower lateral cartilage, or we can say the LR cartilage. So this LR cartilage have the three parts. This one is the lateral most part, another is the medial most part, and another is the part that connect these two parts. So first, this is the medial most part. साफ करो इसको, clean करो and इसको irrigate करो, है ना? So this is the medial most part. So in this medial most part, this is the medial crus. This is the medial crus. This is the medial crus. This medial crus is a very important, and it's a primary component of this columella. It's a really a primary component of this columella, and it gives the maximum projection and the strength to the columella. And it has the two part. One is this is the columellar part, and this is the foot plate part that usually rests on the anterior nasal spine. This is the foot plate part. So usually this tip rests on this foot plate on the anterior nasal spine. So this is the basically the columella part of the medial crus. Usually this area is an important area because we make a inverted incision in this area. And we below this we have a important tip support mechanism, the attachment of this caudal margin with the medial crus. And then the second important part, this lateral most part, this is the lateral crus. And really, it is the widest part of the LR cartilage. So it gives the maximum volume to the tip. And lot of deformity of this lateral crust that usually we overlook during the rhinoplasty, because for a good aesthetic pleasing the tip. So we have the two margin. One is the cephalic margin that we already discussed, because it forms the scroll area, and we have the another important margin, that is the caudal margin of this lateral crust. So this caudal margin is an important landmark again for the marking the marginal incision or for the making infiltration of the local. So this regarding this lateral crust, we have some important thing regarding the size. Either this lateral crust have some deformity regarding the size. Sometimes it have the oversize, and another sometimes it have regarding the shape, because ideally the shape of this lateral crest is convex towards the upside, because sometimes a cartilage sometimes it have like this, like this, like this. That is the paradoxically lateral crura deformity. We have like this. If you come your patient in the OPD and the patient asks, doctor, I have a depression on my the lateral crust, my ala area and the tip area, then you have a sense in your mind, then my patient have a deformity in this lateral crust. This is the knowledge of the normal anatomy, so you can judge the abnormal anatomy. So like this is the paradoxically lateral crura deformity. And then sometimes the another thing, the orientation of this medial crust is also important, lateral crust, because orientation ideally of this lateral crust is towards the lateral canthus. Ideally that should be like, that means we can say the 45-degree from the midline. This is the midline, and ideally that should be from 45-degree. If the less than 35-degree, then you have the cephalic malposition of the lateral crust. During the photographic examination, we find some curving structure on the tip area that we call the parenthesis. So parenthesis deformity. Why? Because look that the both lateral crust, this is my medial canthus. So the direction of this lateral end of this lateral crust is towards the medial canthus, though that is the cephalic malposition of the lateral crust. So ideally we move these directions towards the lateral canthus. That's why this patient have some notching and some depression in this area, because this part support the anterior margin of this ala. So this is regarding the lateral crust. And one more characteristic of this one, sometimes this is very weak. So problem regarding the strength. So we reconstruct it by the lateral crura turnover or by the other graft. So this 3 or 4.
Excuse me, one question. Hello.
Yes.
Sir, excuse me, one question, please.
Yeah. What question you have? I cannot.
Sir,
Speak,
are you listening, sir?
Yes, now I'm listening properly.
Sir, I have a doubt, sir. With this exposure, if the patient has already necrosed this quadrangular cartilage and she wants that augmentation rhinoplasty, sir, how will proceed with this exposure, sir?
Yeah, look that. If you have the augmentation rhinoplasty, the
And
exposure
she has developed, sir, she had this septal abscess which necrosed
Yeah.
her quadrangular cartilage in the past. Now she is 18 to 20 years old and now she wants her tip and bridge to be elevated, sir. And sir, we cannot proceed with this exposure, sir.
Yeah, your question is dear, very good, and really this is the most important thing what you are asking. In my all secondary cases, what I find, someone put just they separate, they make a tunnel and they make a graft on this directly. And ultimately later what happened, the dorsum part is little bit augmented, the graft is moving like this, and ultimate the patient tip have like this. So
Yes, sir.
how you proceed, the things are same. The problem in that case, that once you separate the upper lateral and the septum, You cannot have a good plane in that cases. So I think what should you do? In each and every case, either you have the necrosis, either you have a post-septal abscess or your post-septoplasty cases. I personally realize that this part of the septum is very resistant to necrosis. This part,
Yes.
maybe mostly cases, in my experience, mostly cases, we have this part of the septum. So you just try to the in superior dorsal part of the septum, definitely you find plain. It's the rare to rarest that you complete loss of dorsal strip. So definitely for reconstruction of your augmented dorsum, you separate whatever amount you have the septum, and then you can reconstruct by a long high spreader graft by costal cartilage. So definitely you find, and this is the way. And then because if you have your weak lateral crust, then you reconstruct your weak lateral crust also.
Thank you, sir.
So now we move again. So we discuss regarding the lateral most part, the medial most part, and we have this middle part. So some book mention this is the middle crust, or some book mention this is the intermediate crust. So this part again have the two part. This anteriorly part, this is the dome part. Anteriorly part of the intermediate crust, that is the dome part, and this part इसको पकड़ के रखो मुकेश, and this part posteriorly, this is the infralobular part. So this part is the shortest part of this entire LR cartilage, and really it's a very important part that decide the width of the tip, the definition of the tip regarding the sap also. So ideally the distance between these two dome area, that is the 6 to 8 mm in a female patient and 8 to 10 mm in a male patient. If you have more than this, then you have a broad tip. Like ideal, suppose you have a distance like this, then you have a broad tip. You have a broad tip. And another important thing, there is a good aesthetic relation also between the dome area. Ideally, the relation between the dome area, if like you compare the divergence between the two dome like this, that ideally not more than 30 degree. If you have the more than 30 degree, then you have like this structure. That is a boxy tip. You find a boxy tip. So if your angle of the dome divergence, if more than 30 degree, then you have a boxy tip. So one is the broad tip, then when you have a distance. But in the boxy tip, you have the angle of the divergence is more than. This is the boxy tip. And there is another one term that usually use the bulbous tip. What is the bulbous tip? Bulbous tip is the index between the distance between the tip defining points, and the distance of this between the ala base, the index is more than 0.4, then it indicate the bulbous tip. So I think in rhinoplasty, whenever you use the different terminology, then you should know that what exact the meaning of the deformity, like the parenthesis, like the boxy tip, like the broad tip. So these are the very important thing. And this part, that is the lobular part. So in this lobular part, this is important part that decide the infratip lobule. And a very important part of regarding this dome part, this is the anterior part of the caudal margin of the dome part, and this is the posterior part of the dome part. Marker dena. So look that in this anterior margin of the domal part, you find a notch. This is the notch. This is the region for the creating, we have a soft triangle angle, because we have this notch, dome notch, and due to this notch, we have a very dense skin to skin approximation in this part. So if you have a minor injury in this area, then you develop the post-operative notching. अरे हल्ला नहीं करो. So you have a notch. This is the dome notch, and this is the region for my beginner friends. Then usually we have the soft triangle area, and this is the clinical importance, because we don't have the subcutaneous tissues. It's the approximation in this area. So when you make a marginal incision, then you use judiciously cutting in this area. Another important thing regarding look that Uh, Posterior, this is the cephalic margin of this dome. So in the cephalic margin of the dome, you have this sloping. Ideally, this have this slope. So due to this sloping, and in this anterior septal angle area also, we have some downward sloping. We have the supratip back concept. We have the supratip back. So this is the important relation between this anterior septal angle and this dome area. So this relation is important. Ideally, this dome, that is the around the 6 to 8 caudal to this anterior septal angle, and around 3 to 6 anterior, and that's why we have the supratip brake. So this is the important thing you should know regarding what is the exact height of my tip, because this is a frequently question asking by my beginner friends. Then how much we have this tip regarding that, because how much tip have the more anterior of this septum, how much we have the more caudal and the anterior. So this is the normal relationship. The old Rolling Daniel book, they have a very good chapter, not in the new book. If you find the old Rolling Daniel, he have a very good mention this relationship. So these are the important thing we discussed regarding the anatomy. Now we move to the further steps. Lateral crural retractor lagana. And if you have any questions regarding the anatomy, because you learn the normal anatomy. This is the advantage of the open rhinoplasty. I have this lateral crural retractor. This is the lateral crural retractor. This is the good instrument, and this invention by the Najim Circus. So you make like this. So the everything is now in front of you. So now I just separate this anterior mucopericondium in the inferior part, in the posterior triangle in the septum area, because this septum have, this is the caudal part of the this is the dorsum part of the septum, this is the caudal part of the septum. And just for knowledge of my beginner friend, then the angle between this dorsal part of the septum and this caudal part of the septum, this is the anterior septal angle area, because this anterior caudal part of the septum have three angle, but clinical point of view, this is the only important angle. Another, we have this posterior septal angle area, the angle between the posterior part of the septum and the caudal part of the septum. So now we, this is the part of the depressor septi muscles, and then we deglobing this mucopericondium section dena. So now everything in front of you. So why these patients have like some over projected nose, and it appear there is a obtuse nasolabial angle, and the nose is just like a tension nose, because look that we have this axis part of the septum. Due to this axis part of the septum, and why the nose is deviated on one side, because we have this axis part of the septum, this axis part of the septum. So this axis deviated part itself have the intrinsic force on the septum. So for dealing, we release this intrinsic force of the septum. This is the characteristic feature of the crooked nose. So first we correct this part. So now again, because a common mistake done by my beginner friends, once they expose, then they create a L state and they harvest the septal cartilage. I think this is the wrong method. After complete exposure of septum, you have a second look properly, and if you have a axis part of this septum, if you have a axis part of the this septum, first you excise that part. Otherwise, you weak your L strut. Okay. Suppose if you harvest the septum cartilage and then you deal with this part, then you weak your lateral crus. So first we excise this axis part, because we have this cartilaginous bump. So we excise this cartilaginous bump, 15 number blade on.
Snil, first mark it. How much you want to?
Yes, yes, boss, yes.
Yeah.
So Dr. Kapil is always I learn a lot of things whenever I met him. So the marking habit is good habit. So just like we mark this axis part like this. Okay, इस तरह मार्कर भैया प्रॉपर नहीं चल रहा. Yes, on both sides you can mark on this side also. So this is the axis part. Earlier there is a method to unblock removal of the bump, but I think incremental removal of the bump, that is a good. So cartilage holding. So I just wherever I mark, then I place my this forceps like this. इसको पकड़ो आप. You ask your assistant नीचे से पकड़ो, ठीक है. Yes. And give me the tooth forceps. And then yes. 11 number blade या 15 number, ठीक है. So then just I excise this whatever we have the axis part. Yes. So this is my axis part that I excise. Yes. Okay. This is my axis part that I excise, and now anteriorly also ये लगाओ, यूं लगाओ. Yes. So now राजवीर को बोलो ये थोड़ा सा यहाँ फोकस करेगा. एंड ये थोड़ा सा दिख नहीं रहा, बस ऐसे पकड़ के रखो. आई थिंक ठीक है. नाउ इज गुड. एवरीवन हिज थिंग्स आर विजिबल. So now we have this axis part. First, you just secure that both sides you complete degloving, and this is a part that we have mark कर देना. This is the part. Yes. So this is the part that gives the tension in the nose. This one. Yes. So we excise this part. This is the part. Yes. So just yes. Yes. So this part we excise. Yes. So now we just check. Now we don't have the tenting, otherwise we have a tenting of this one. Now we again mark for create my strut. Marker dena. Give me the marker. So at least we recommend at least 1.12. I think the 1.5 centimeter is good to preserve the dorsal and the caudal part of the septum. Marker दो यार. डॉक्टर पॉन ने ज्वाइन किया क्या? डॉक्टर संदीप पॉन ने और डॉक्टर घैसास ने ज्वाइन किया. देखना अगर हो तो फिर, है ना. So now we just mark. वो देना अपना मेजरमेंट वाला. मेजरमेंट है ना. I usually not like mark this, but for my beginner friends, then you can mark like the. Huh?
The left side is visible on camera, so you mark
No,
on
no,
left side.
I show. I think now is visible, boss.
Oh,
Okay.
okay.
Okay. Now is visible. Now is visible. Now is visible. And now, like this is around, I think the 1 centimeter. So I think this is the 1 centimeter. At least 1 centimeter you should have like this. If you have the more than 1 centimeter, that is good. Okay. So now if marker dena, we have like this. And then the important thing, when you move, then not acute, that should be not acute like this. So this is my marking. This is my marking.
Yes, it's looking good. Very
Thank
good.
you, boss. Thank you. Now give me the knife. Give me the knife. This lateral crural retractor is really very good instrument. So things are visible. Now I think visible my marking. And now I use this 15 number blade just make like this. Blade बदली के भैया आपने. And then just I, in the curving manner, I move, not acute. Yes. So my incision superiorly and the inferiorly complete. Now, what is the further next step? वो दो ना मेरे को nasal. Yes. So this is your Killian's nasal speculum. Just one prong on this side and another prong is like on this side. This is the simple methods. So now on in this way, now I deattach the posterior part of the septum, posterior attachment of the bony and the cartilaginous junction. I usually use this sharp periostem elevator and sharp end of the storage periostem elevator. This is the good instrument. So I just go the posteriorly and just like this. Yes, this is my junction. So just first go posterior and then I come back and wherever I find the junction, then ये थोड़ा सा मेरे को 15 नंबर और देना because it's very important step. Otherwise, if you pull it your septum, then you create the injury. La. Now I just deattach like this, like multiple perforation. Like multiple perforations like this. Yes. Now the inferiorly also. Yes. Yes. So I deattach posteriorly from rest of the maxillary crest area, and once you assure that I complete deattach, then you need the cartilage holding forceps. This is a very good cartilage holding forceps, particularly I purchase for the ribs holding, and then you hold it and then you move it and you just little bit pull it. If you feel the resistance, then you just again check it, and wherever you have the attachment, you first deattach it. If otherwise you pull it forcefully, then you have the some complications. So look that I have this part of the septum. So this is the superiorly attachment. This is the anteriorly like this. This is the superior attachment with the dorsal strip like this, and this is the anterior, and this is the deviated buckling part. So we have this part, yellow. Now I check because my patient have the uh, functional purpose, functional complaint. So rest of the septum, I have to correct it. So because the bony part is also deviated, so वो देना seizure देना, terminate seizure. You can use the bone cutter also. There is a good instrument by the Medicone. I usually use this turbinate seizure. Yes. And now give me the cartilage holding forceps. So this is the deviated part of the bone. This one. Yes. Hold it. Suction. Still we have the deviated part. So we have to correct for the functional purpose. Periostem elevator. And whatever amount of the residual cartilage, septum cartilage, you try to remove as a big piece so you can use for the reconstruction. Whatever you have. Suction. एक बार वो देना. लो, periostem elevator. So we just now deal with the vomer and maxillary crest part. Yes. Suction and gouge and hammer देना. Yes. Periosteum elevator. Because on the left side we have a spur, so yes, hammer देना. Yes, yes. Just behind the anterior nasal spine. You not damage the anterior nasal spine. Yes, yes. Suction. Because the functional correction is important. Now, lux. You can use lux or you can use this. And it's also again the important thing, like sometimes when we have this spur, then if you pull the spur, then you have a tear in your mucopericardium. So what you do then, once we rotate this and then again you medialize it. So this is the spur of this on posterior. So once you rotate it and then you again in the midline, otherwise you have developed the injury in the flap. Yes, now let's go now. A little bit. Sometimes if your bony part of the septum that is deviated but don't have any spur, then you can fracture it in the midline. But if you have a spur, then definitely you can remove. Now we correct I check the both sides my nasal cavity. We have this small लो वाइट डबल प्रोंग रिट्रैक्टर लगाना है यहाँ पे. Yes. Tooth forceps. So if you see that this is my septum, this is my septum, this is my septum. So how this part of the septum still have the deviation. So I correct this part of the axis part of the septum also. 15 number blade, 15 number blade. So now we release the pressure on the septum. Yes, I again reposite it in the midline. Yes. वो देना nasal वाइड डबल प्रोंग रिट्रैक्टर. यस, ऐसे पकड़ो, ऐसे पकड़ो, यहाँ पे लगाओ इसको. Your caudal part of the septum, you just need in the midline actually, otherwise your tip is deviated. This is the cartilaginous part, and you identify this is my anterior nasal spine. 15 number blade. Give me the 15 number blade. Because the mostly problem in this patient due to in this part. Yes, I just harvest little bit more. Yes. Now we release this excess tenting on the septum. Yes. Now we fix in the midline with the anterior nasal spine. So again, how you fix is the important thing. There is a different method just to fixation of your septum, caudal part of the septum in the midline with anterior nasal spine. So many renowned surgeons, they beautifully use, just they make a hole in the anterior nasal spine and then they fix it. But I think that is little bit tough. For my beginner friends, there is a easy method. First, you identify this is the anterior nasal spine. So then you can just use the periosteum of this anterior nasal spine like this, one side like this, and then on another side by this is the 4O PDS suture. So you can fix by this periosteum, इसको पकड़ के रखो, and then like this through the septum. This is the easy methods, because in all patient we have, I personally feel we have very short antenasal spine, not in Caucasian patient. In Caucasian patient we have a long antenasal spine, but it's again is a matter of hardly. Dr. Gaisas, he fix very beautiful, just he make a hole in the antenasal spine, but usually I fix in this way. So in rhinoplasty, how you do, I think how you more confident, that is the important thing. The things should be correct, that is the more important. So now then we just fix it in the midline like this. You can use the 3 OPDS also. I use usually the 4 OPDS. Yes. Yes, yellow. So give me the cartilage holding forceps. Cartilage holding forceps. Yes. Peg देना. Give me the peg. Give me the peg. So now I put the peg on both sides because my septum work is now almost complete. Dorsum part we deal later. We move or fourth step or 4G step, that usually we have a sequence. So in the fourth step we move for the Bony vault modifications. Scissor देना. Scissor देना. इसको काट. So now yes. So now the problem in this patient regarding the bony vault is the bump on the nose. Usually in the mostly patient, when we correct the bony vault, then we have like the deviation of this bony vault. So we use the different type of the combo of the osteotomies. But this patient doesn't have regarding any deviation and doesn't issue regarding the width also. So we deal with the different way. First we correct the bump and then we do the rhino sculpture also. But just for my junior colleagues, little bit I discuss the osteotomy part also. Marker देना मेरे को एक बार. Like suppose this patient have a deviated dorsum, then we use the different type of the either the right side or the left side the deviations, or either so one side the nasal bone is the concave and one side is the convex. Then in this patient we use different osteotomies. Usually osteotomy use that is the one is the median osteotomy, another is the lateral osteotomy, one is the intermediate and the transverse. Four osteotomy usually we use. Uh, I think if you just ask me, there is a simple formula for using the osteotomy like the IP square. That means the first you know the indication of that osteotomy, and then you need the placement of the osteotome, where you exact place your osteotome, and what is the pattern of your pathway. If you learn the three things, that is good for using the osteotome. Either you use the external or either you use the internal. So regarding the paramedian osteotomy, मेरे को वो देना एक एक मिनट इसमें ये 15 number blade देना. So before just we discuss regarding the, I just lift up the periosteum. Then we discuss regarding the osteotomy also. So look that this is my bony bolt. So I just make this is the blunt end of this 15 number blade. So I make a incision like this. I make a incision like this on this side also, on this side also, on this side also. And now you give me the periosteum elevator देना, स्टोर्स वाला देना, स्टोर्स वाला periosteum elevator. First we find a plane, right plane. So look that this is my periosteum. This is my periosteum. Suction and clean करना field को, suction करना. So this is my periosteum. Okay, and on this side, so this is the Joseph periosteum elevator. This is the Joseph periosteum elevator that we usually need. So I just scrape this periosteum on both sides and then we join in the midline. Yes. So before to rest, and then if your complete degloving your plane, that is the sub periosteal manner, you have a scrape sounds. So look that this is my bone left side, and now on this side yes. Yes. So suppose this patient need the median osteotomy. So in the median osteotomy, like indication, we know that whenever you use the median osteotomy, either the lateral osteotomy, if you need the indication, then after the indication, like the where you place your osteotome देना. So where you place the osteotome, so to a memo वाला दे देना, medial osteotome देना. So where you place your osteotome, that is the important thing. So the junction, this is the junction. This is the junction between the nasal bone and the bony septum. So now this is the junction where you engage this osteotome. Okay, if suppose this patient is करना नहीं है इसमें, suppose this patient need the osteotomy. Okay, and then now you have the two system, two pattern. Then either you just go in the straight manner, or either you just go in the superior oblique manner. So suppose if your patient you do the lateral osteotomy in the high manner, then you just go superior oblique manner, like in the 15 to 20 degree fade away condition. So we separate this nasal bone from this septum, bony septum. So we actually engage this osteotome in the few millimeter lateral to the midline. That's why we call the paramedian osteotomy. So you never confuse between the paramedian and the median osteotomy. And another important thing regarding this one, the upper limit of your osteotomy, that is like, look that this is the intercanthal line. So the intercanthal line, that is the upper limit. If you go the straight, then this is the way, this is the pathway, just like this, and you stop at the intercanthal line. And on lateral osteotomy, when you do the low, then you need the transverse osteotomy also. But sometimes, like if you go like this, like in the superior oblique manner, like this, then you meet with your lateral osteotomy. So this is regarding the paramedian osteotomy. Either you just go the straight and just you go the superior oblique manner. And now regarding the lateral osteotomy, for lateral osteotomy, we have the two osteotomes. देना मेरे को. We have the two osteotome. This is the Medicone instruments. We have this is the guarded osteotome, and one is the दूसरा भी देना. One is the unguarded osteotome. दूसरा वाला जो था ना, वो मंगाओ. So this is the guarded osteotome. These guarded osteotome one have the two right side and left side. They are the different. So one side, this is uh, the right side and this is the left side. So this is the guarding end and this is the cutting off the end of the osteotome. Okay, for my beginner friend. So how you place this osteotome is also the important. This guarding end, that is the outside of the nasal wall, and the cutting end, that is the inside. So right and left side, if you use, that is the easy. And sometimes when this is the curve, there the right and left side both, and this is the straight one, that have the, you can do right or left side both. I usually use this the right on left side. Now I think if you go by the external method or the internal methods for the both thing, if you, I usually do the internal continuous lateral osteotomy. So again, the important thing, where you place your osteotome. So give me the nasal speculum. So where you place your osteotome, then you just look that first you identify your margin of, clean करो इसको, your margin, I think anterior margin of your anterior end of your inferior turbinate. This is my inferior turbinate because it's very confusing for my beginner friend. So this is the anterior end of the inferior turbinate. So I just make a horizontal incision in this area around the 3 millimeter, and then we engage this osteotome. दूसरा वाला देना, इधर का osteotome देना. So because this is the right side, so we engage like in this way. And we just hold around the 70-degree, and then we ask your assistant tap, 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 and then your pathway of the osteotomy is marker dena. Either you use the external or the internal. This is the nose and nose pyramid, and this is the cheek. So where the nose and the cheek have the attachment, this is the nasofacial groove. So in this nasofacial groove is the ideal, the pathway of the lateral osteotomy. So suppose lateral osteotomy देना, वो देना इधर वाला देना, curved वाला देना. So suppose we engage it like this is the 15 number ये देना. So this is my area. This is my area where the attach the anterior end of the inferior turbinate and the this upper lateral cartilage. So I engage in this like this one. So I preserve this Webster triangle area. Now I just move like this, like this, like this, and then once I reach at the level of the medial canthus, then I rotate this superior oblique like this. Superior oblique like this. So the pathway of this osteotomy just like a banana shape. So this is the high, then low, and then high. This is the high, low, high pattern of the osteotomy that usually we use in internal continuous manner. Advantage of this one, because we preserve this Webster triangle area, so the patient doesn't have any functional problem later. And then sometimes, because in the low to low, you enter in this thick part of the nasal bone, and the some part of the nasal bone is free. So the patient ultimately develop a small piece of the nasal bone is free and have the forward and bending moment that we call the rocker deformity. So if you have like high, low, high, then once you reach on this level, then you rotate your osteotome, then you can prevent injury in this part and you can prevent the rocker deformity. So this is the advantage of the high, low, high osteotomy. And suppose on the other hand, if you can use the external manner, then you use this 2 mm osteotome. Then you use this 2 mm external osteotome. So just like in this is the nasofacial groove. So in the nasofacial groove, we just make a step incision, and then by swapping action of this one like this and this one like this, you use the multiple perforation just like a postage stamp manner. And then ideally you have a 2 mm distance between the two perforations and you do the green stick fracture like this. So then you can entirely mobilize your bony vault. So the aim of osteotomy is then we want to separate the rest of attachment of this bony vault from the rest of the maxilla and the midline. But in this patient, because this patient don't have any issue regarding the width of the nose. We just do little bit rhinosculpture in this area. So this is the median and the lateral osteotomy. And sometimes when your patient need the transverse osteotomy, then again this intercanthal line is the area where you place your osteotome, and then same you make a horizontal incision, stab incision, just like external osteotomy, and then you just free the attachment of the superior attachment of this bone and you can mobilize according to your use. So these are the osteotomy, and sometimes you when some your one side of the nasal bone that is concave and another is the convex. So in that case, because we need the more movement of this lateral nasal wall, so in that case I think if you do the intermediate osteotomy, that is the better. So that is the same because this is the uppermost part and this is the lowermost part. So you mark between mid part and the same multiple perforations. So then you can have the more movement of the lateral nasal wall. But when one side you have a convex and one side you have a concave, then the sequence is definitely matter. First, your osteotomy that should be on the concave side, because once you do the concave side first, then this part is free. So the convex side, when you do the osteotomy, that this part allow this convex bone in the midline. So this is the advantage when first you do the high osteotomy first. And now give me the वो देना इसको वो लगाओ. So we just rasp the bump. So for the rasping of the bump, you have the different method. Either you can use like the Medicon rasp, but when you have a gross bump, then you can use the powered instrument also. I use the drill in this patient. Dr. Kapil Bose, you want to add something regarding the osteotomy? Badena.
No, you have explained very well. The median
Okay.
osteotomy, you have explained very well that there are two types of paramedian, the straight
Yes.
paramedian or oblique. So
Yes.
when you do oblique paramedian and then lateral will meet to the medial oblique paramedian. So you don't have to do horizontal osteotomy in those cases.
Yes, exactly.
When you do straight paramedian and lateral osteotomy, then you have to do horizontal osteotomy to meet the all three
Yes,
together.
yes. Because in RCCon meeting, I saw Dr. Gaisas, he the high, is the low to low, and he use the straight manner, but he do the transverse osteotomy also.
Yes, yes.
Yes. So वो देना Goxel वाला elevator.
So what are you going to do with this bump
I,
now?
I was rasp the bump. I the rasp the bump because.
Okay.
So now we have this. This is a very good instrument by invention by the Goxel. So you have the both the suction and the periosteum elevator both. So then we lift up this one and then we just rest this like. So first in this key area. So this is the advantage and beauty of this instrument. तो आ रहा है उसमें एक को फोकस ऊपर करो, वहां पे उसमें फोकस नहीं, फोकस करो उसको, या थोड़ा सा ऊपर कर दो क्योंकि हाँ यहाँ ऊपर आ नहीं रहा, यहाँ करो, यहाँ पे फोकस करो, अभी तो हमको थोड़ा ऊपर का फोकस कर दो, यहाँ पे है ना, यहाँ पे. यस, नाउ इज गुड. तो हाँ बताओ बताओ क्या है.
The question from Dr. Arpit Agarwal from Delhi.
Yes.
At the bony vault, the dissection should be along the periosteum or under the periosteum.
Under the periosteum, because if you over the periosteum, dear, then you have a lot of edema. So always you just subperiosteal.
So one question from Dr. Anil Reddy, Karnataka.
Yes.
If accidentally cut lower lateral cartilage,
Yeah.
medial crura can be repaired.
Yeah, definitely. Because every surgeon have their complications. So in the beginning time and you have the injury, you never panic. You whatever you have the injury, definitely you repair that things. It's the blunder. If you are not repair, then you develop the etiogenic deformity. Whenever you have the injury, because sometimes when you make an incision, then you have injury in the medial crust and the dome area, then you repair by 6 sutures. Okay.
So one more question from Dr. Naveen Kumar, Andhra Pradesh.
Yeah.
Are there chances of columellar retraction post surgery with the incision you made? With this incision?
Then no, not at all. Why we have the retractions? There is no chance of the retractions.
Thank you, sir.
The retraction, columellar retractions, the incision is not a problem. When you not deal properly your septum, caudal part of the septum, then you develop the columellar retraction. Yes. You can do this work with the Piaggio also, but that will take more time. So this is the good thing. Yes. अभी आ रहा है उसमें? Yes. Whatever you do, then everything that should be incremental manner, you just check it. Yes. पकड़ो इसको थोड़ा सा दिखाओ. So the advantage of this elevator that have the both the suction and the elevator. This is a very good innovation by the Goxel. Now I just check once, but still we have more. So just yes,
Hello,
yes.
there is one question. What is the use of cephalic trimming of lower lateral cartilage and what is the indication, miss? In which
Yeah,
case-
yes. The role of the cephalic trimming dear, basically, when we have a big volumic tip and then after opening you find you have a big size of lateral crust. I think in Indian patient that I 8 to 10 mm is enough. If you find then your lateral crust size is more than 10 around the 15 mm, then the cephalic part of the lateral crust you excise. So for just to make the reduce the volume of your lateral crust and to make the more malleable this lateral crust, we do the cephalic trimming.
After a long time, what is the result? Means rotation of the LR
What is saying?
after cephalic trimming.
Yeah.
So what will be the result that you will get?
Yes, definitely. Sometimes when you want to the refine the nodes and if you want to reduce the volume of your tips, then you can do the cephalic trimming. But I think my advice that we in India we have very thick skin patients, so you never a big fond of like for the cephalic trimming because if you reduce more and more the inner framework of your nose cartilaginous part, then later the nose is sunken and the patient develop the LR retraction. So whatever technique you use, is there indication or not? First you check that. But definitely when you have a like a female patient and you need a good refined tip, then you can definitely use the cephalic trimming.
In beginning, you have mentioned that subperitoneal dissection. If
Yes.
patient are having thin skin, uh, in that case also you are doing this subperitoneal dissection.
Suprapericordial dissection, not in the
No, no, no.
subpericordial.
No, no, what I am asking that you are dissecting above perichondrium to
Yeah.
expose the lower lateral cartilage. In
Yeah.
some cases, the thin skin, then you have to dissect subperichondrial.
But still we are the suprapericordial. Once we deal the upper lateral area, then we go the subpericordial for dealing the upper lateral. But ideally the dissection that is on the dorsum, that is the suprapericordial.
Okay.
Yes.
Dr. Sunil, may I interrupt here?
Yeah, definitely boss. What's
Yeah,
here?
what he is asking, if the patient is having very thin skin,
Yes.
in those cases, you prefer going subpericordial because
Yeah, you
it is
can do. Yes, I am agree.
usually it is paradox. Whenever the skin is thin, cartilages usually are very tough, and whenever the skin is very thick, paradoxically the cartilage is very thin and very weak. So in those cases, whenever you see very thin skin, it's better to have subpericordial dissection. So you take the pericordium with the skin flap. So later on you can put it back because the cartilages are very tough. So that there is no chance of weakening the cartilages in those cases.
Okay, fine.
Yes, absolutely right. Because if your patients have a like, because this is the in the rhinoplasty surgery, there is no single technique then you can follow in each and every case according to your patients, what deformity your patient and how your ethnic variety of your patient and what your patient want, that is more important. Sometimes you feel that definitely your patient needs like osteotomy, but if your patient doesn't want, then I think you never try to do. I think this is my personal opinion. Dr. Kapil Bose, what you say? Because the patient's right is most important.
Yes. Depending on the need, you do that.
Yes. Because what your patient wants, that is more important. Because sometimes we decide that this patient needs some LRS excision, but patient say that I'm okay with my this part. So that you never touch that part. Because if your patient is happy, then everything is fine.
So there's a question from Dr. Deepak Chandra from Gujarat.
Yeah.
Kindly explain spare roof technique.
Spare roof techniques. You know, we are doing Dr. Open structural rhinoplasty. And that is the different era you discussed regarding the preservation rhinoplasty. That is a totally the different thing. So in spare roof technique, look, we in this case we open the roof of the nose by the removal of the bumps. In spare roof, in preservation rhinoplasty, what they do basically grossly, they preserve the roof attachment like the bony and the cartilaginous, and they deal with the lower part. Either if they want to reduce this bump, they excise this lower part of this bony vault, so automatically they come down. So in the spare roof technique, they never disturb this part. They excise this lower part of your the bony vault. So that is the totally different thing regarding that is the preservation rhinoplasty. We are doing the basically open structural rhinoplasty. So there is an open roof technique just for preservation rhinoplasty.
Yeah, sir. Good afternoon, sir. From Mumbai Center, Doctor wants to one query.
Yes.
So I wanted to know if is there any preference to do a bony hump reduction before you do a septoplasty, or is it okay to do it later as well?
Yeah, my sequence that I first do the septum work, septoplasty, and then usually I do the bony work. So this is my sequence. And then again, it's a matter of your confidence. Then, but I just prefer the before to the tip work and the septum reconstruction, the bony vault modification, because that is the little bit crude work. अभी थोड़ा सा bump हो रहा है थोड़ा सा.
Okay,
Yes.
sir, and in case post bony hump removal, if you experience a open roof deformity, then do you go for the osteotomies, or in this case you will still not?
Yeah, suppose a patient have a open roof deformity. Open roof deformity usually happened when you exercise the more than 5 mm, more than 5 mm, either the bony and the cartilaginous part. Then if you develop, if you feel your patient develop the, then do the lateral osteotomy for correction of the open roof deformity, or then you use the spreader graft. No. Yeah.
Thank you very much.
The question from Dr. Siddharth Day, West Bengal.
Yes.
So could you elaborate a little about the keystone area, internal and external nasal valves, and their importance in a patient presenting with nasal blockage sensation?
Yes, yes, definitely. Once we do this work, then definitely I explain that, because earlier regarding the internal nasal wall area we discussed. The keystone area is basically junction of the four important structures of the nasal bone and the upper lateral cartilage and the bony septum and the cartilaginous septum, and that is not a point, that is a area, and it's the key area. Why? Because this upper lateral cartilage gets maximum support from this area. So I just check. Because continuously you check your nose this little bit more, and the rest mostly bump has gone. लो एक थोड़ा सा और देना. So this is the advantage of the powered instrument. Otherwise, it will take lot of time. Now, yes, just you stand behind the patient, and just we have this little more bump.
Ask him to give the lateral view so you can have the idea.
यस, थोड़ा सा ये व्यू देना, लेटरल व्यू इधर से दिखाओगे आपको उसको. नहीं अभी है, बट थोड़ा सा बहुत लिटिल बिट आई फील, so I need more rasping little, then I show you the lateral, because you have a grossly bump in this area. So just we check it again. Sometimes if a patient have a very thick lateral nasal wall, then in that case also you just read or do the rhinosculpture in the lateral osteotomy pathway, and then you can do the osteotomy that make the easy, because sometimes when you thick lateral nasal wall. Yes. राउंड वाला देना, राउंड वाला, राउंड वाला, और अपने पास जो दूसरा वाला है वो और देना, थोड़ा सा देना, थोड़ा सा लिटिल बिट. गिव मी द. नो, वो देना, लिफ्ट. Dr. Kapil Bose, what technique you usually use when such type of the patient have a gross bump? लो, इसको दो ना इस. लो. सही. Yes. Now we have almost, the bump has gone.
So Dr. Amrita Basu from West Bengal says, very good hemostasis. Any tips for such clean operative field?
You are always in the right plane. When you are in the right plane, there is no bleeding. You have your operative step already in your mind, then no step. Your operative step that should be sequential. Otherwise, if you are biased, if you are the confused, then you have the lot of problems. So once you do the more and more cases, then you develop automatically all these things. The blood pressure of the patient is also important. My anesthetic, that the blood pressure of the patient, that is around the 80, almost in systolic, that is almost in each and every case. So these are some important things.
Sir, instead of burr, do you use pizzo knife?
Please repeat your question.
If you don't have a burr, can you use pizza?
Then if you don't have a bar, then you can use a rest. But when you have a gross bump, then by the rest it's too difficult. It will take a lot of time. So then you just excise the bump by the Rubin big osteotomes.
Regarding Miss,
I think it's very easy, because almost all our ENT colleagues, they have the simple that I use the same marathon drill that we usually use for the ear surgery, and you just purchase these burrs. It's not some different thing.
Sir, what is your experience for the fillers? Have you ever used the filler for the small defect or small
For the
depression? Small depression over the nose.
small depression on
Nose. Have you
fillers.
ever used filler? Yeah.
That is a different topic. I think if you have, I usually not fond of, but definitely when some your patient need just only a small depression, then you can use the hyaluronic acid. But I think you should have the thorough knowledge regarding the depth of the knowledge, regarding the management, because sometimes the filler, if due to the retrograde embolization in the particularly in the nasofrontal suture area through the anterior and posterior ethmoidal arteries, filler ultimately reach in the central artery of the retina, and in the study the patient reported the blindness. So you definitely wherever you need, then you can use the fillers, but you have to know the thorough knowledge of the regarding if some disaster develop, then how can you manage, what exact depth of your infiltration of the fillers. So I'm not routinely do the fillers. I'm routinely do the open rhinoplasty. So definitely, if you need, then you can use, but with all your precautions. ठीक है, थोड़ा सा मेरे को अभी और लग रहा है यहाँ पे. यस. Just little bit more, otherwise this work, rhino sculpture is complete. Yes. So now you can show the lateral view. ये इधर से दिखा सकते हो? वो देना, रेस्ट देना, सिंपल वाला, मेडिकॉन वाला. Just little bit refinements. Just little bit refinements.
Sir, we would like to see the pre-op photograph of the patient, sir.
Yeah.
We would like to see the pre-op photograph of the patient, sir.
Yeah, definitely. I pre-op photography, and in mostly cases intraoperative photography also I usually pre-op photography, and then after the photography we have the printout of that photography in my I routinely I just paste in my OT in front of my operating table, so we can assess the things. These are the good things. Yes. So now ये जा रहा है, व्यू जा रहा है आपका? थोड़ा सा दे.
Hello. There is a question from Baroda.
Yes. So now we almost have the bump has gone now.
Hello.
Yes, I hear you.
Can we achieve this bump reduction via closed reduction also, sir?
Bone reduction.
The hump we have removed via open procedure. can we reduce this using closed rhinoplasty also?
Yeah, definitely you can do sometimes if your patient have don't problem and not complain regarding the tip or something and you want to exercise only the bump. Then आप उधर लगा लो. Then उधर लगा लो. Then definitely you can do by the. But I think sometimes you have a gross bump, then it's very difficult. But again, it's a matter of experience. Dr. Ali, he's a very good doing the internal oval cases by the endonasal rhinoplasty. So it's a matter how you are more confidential enough.
Okay, okay, thank you.
I usually prefer the open approach and I ask to my beginner friend also because you learn lot of. When you open, when you in front of everything, then you learn lot of things. Yes. अब लगाओ self retaining लगाओ. Bump has now gone. Self retaining लगाओ. Because the advantage of this open rhinoplasty, we have only the one disadvantage, that is the scar of the incision. But I think if you close it meticulously, there is no problem until unless the patient doesn't have any scar tendencies. Yes, you remove that one. Yes. Now sharp scissor. Give me the sharp scissor. Give me the sharp scissor and.
Are you planning to do spreader flaps?
Yes, because this is a good thing because this patient have in the frontal view we have like some narrowing on this mid-vault area. So I think if it's a better if we use this axis part of the upper lateral cartilage as a spreader flap.
Okay.
Tooth for सब देना. So then first we just remove this is the perichondrium, this is the perichondrium. So we separate the perichondrium and look that I think you can see very well. इसको पकड़ के रखो, इसको पकड़ के रखो भैया.
So there's a question from Dr. Samanvaya Soni from Rajasthan.
Yes.
How to manage rocker deformity? How to repair the scroll area? The scroll area.
How to repair the scroll area? You know the scroll area damage, usually you have the chance when you have a cephalic trimming or sometimes when you have the lateral crura flip and whenever you just reorient your lateral crust. So usually the scroll area is not damaged, but at the last when you just again reposition your lateral crust, then you make a suture. Like in this patient, I demonstrate then how you reconstruct the scroll area. इधर ही पकड़ो. So when you rotate this upper lateral cartilage, and it's the important message that first you remove this perichondrium. ऐसे रखो आराम से एंड सेलाइन का इरिगेशन दो. Throughout your syringe, ask your assistant, there is saline irrigations, that is a good. So every patient have a different technique. You never biased. Because in a lot of workshops, the patient, the surgeon have the different technique. But like in this patient, you can use you excise this axis part of the upper lateral, and then you can use the spreader graft also. But my motto, because I want to deal the width of the mid wall. That's why I'm just doing this rotate this axis upper lateral part of upper lateral cartilage, superior part of the upper lateral cartilage. Yes, love. Okay. 4 PDS suture. So this is the axis part of the upper lateral. Then we just rotate it like this, like in this manner. Yes, give me the one more. एक और देना. Yes. So I rotate this part. इसको यहाँ से पकड़ो, इसको यहाँ से पकड़ो, यहाँ से बस. ठीक है. 4 OPDS suture. So this 4 OPDS suture.
Apply needles.
We can apply the needle also. That is the good. Then when you apply the needle, then the things are stable. So that is a good advice, but
So question from Dr. Debangshu Ghosh from West Bengal. What is the size of the burr tip being used?
Devanshu, I don't know exact what is exact site of this exact size of this bar, but definitely I'll update you, because I in my Berlin meeting I purchased these bars, so I don't know what exact size, but definitely Devanshu, I update you regarding what exact size.
So question from Dr. Sanjeev Golhar, Maharashtra.
Yeah.
Do you disturb keystone when you do median osteotomy?
You never disturb the keystone in median osteotomy, but dear, sometimes in a crooked nose case, because sometimes the septum is so ossified, when you make a separation between the bony part of the nasal bone and the bony part of the septum, then and accidentally sometimes the septum is fall, keystone area is damaged. So I recommend another technique that I learned by Dr. Pond, that you just can go the transvestibular paramedian osteotomy in the osteotomy देना in the medial osteotomy वाला. So in that technique, like suppose when we routine osteotomy, we engage in this manner. But in transvestibular paramedian osteotomy, what you do, like you just go through the nasal cavity like this, and then you just bypass this keystone area, and then you do the osteotomy if you have the fear. And then I think you can prevent the injury of the keystone area, and this is a good methods to prevent the injury of the keystone area. Suture dena. Because the prevention is the better, so you try to prevent the injury.
Question from Dr. Archie Mala, Uttar Pradesh.
Yes.
What are your views on piezoelectric ultrasonic rhinoplasty?
I have the Piaggio. The use of the Piaggio ultrasonic rhinoplasty, sometimes suppose this patient need the osteotomy, and then sometimes when your nasal bone and lateral nasal wall is thin, then you can use just for the rhino sculpture, you can use the lateral osteotomy and the paramedian osteotomy, and sometimes you need like bony and circular sutures. Then you just make a hole in this lateral nasal wall, then you can use. Only problem in the Piaggio that we have a very thick, strong nasal bone, thick, strong lateral nasal wall. Will take a lot of times. Otherwise, sometimes when you have a female patient, you have a small lateral nasal wall and weak lateral nasal wall, then you can use for the rhino sculpture and for the osteotomies. But the same work you can do by this burr. Cut it.
The question from Dr. Arpit Agrawal, Delhi.
Yeah.
In crooked noses, we often find upper lateral cartilage deviated and fibrous.
Yeah.
How to address it?
Definitely when your upper lateral cartilage is deviated, then because the more roll of that is the septum. So when you use the spider graft, then you can use the clocking sutures also. So the clocking sutures that help in the correction of the upper lateral also. The technique of the clocking sutures, then you can use suture from more cranially in this upper lateral and the more caudal in this septum just for rotation of the septum. So you can use the clocking sutures and the spider graft for correction of that. इसको ऐसे पकड़ना. Yes. थोड़ा सा एक बार निडल देना. थोड़ा एक मिनट. Yes. Needle देना एक बार. Yes. One more needle.
So another question from Dr. Arpit Agrawal, Delhi.
Yes. एक suture और देना.
In this case, there is a slight curvature in the dorsal strut. Are you planning to correct it?
Yeah, because still the septum is free. Definitely we correct it because still because the septum is free now. So that's why there is a curving. We correct it. Suture देना. Because when the cartilage is free and the cartilage have the memory, so cartilage like every cartilage have the warping tendency. Yes. So basically the spider flap is another form of the spider graft. वो कैसे आ गया उसमें?
So question from Dr. Kirti Kumar KC, Karnataka.
11 number.
Can we use Vicryl?
You can use, but there is a logic. Everything like I usually use the PDS sutures because the PDS have the long half-life around the 180 days. But you can use the Vicryl sutures also, but I think the PDS is the good. I usually use the PDS suture. छोड़ो. So I remove that suture because now I free that perichondrium so that we cover the perichondrium later. इसको पकड़ो. So you keep the patience because sometimes when you do the such sutures.
So question from Dr. Gorakhnath, Uttar Pradesh.
Yeah.
Which suture material is it?
This is the 4O PDS sutures. This is the 4O PDS suture. Yes. Sometimes when you don't have like much bigger this end of the upper lateral cartilage, then you use the spider graft. But I think in the rhinoplasty, whatever graft you use, then first you know the indication of that graft, ideally the purpose of that graft, and then you know regarding the ideal dimension of that graft, and then how you place that graft, that is the important. It's not necessary then each and every patient we need the every graft, and whenever you open the upper lateral and the septum, then you need the like spider graft. There is a certain indication of the spider graft, like when your dorsal septum is deviated, when you have a existing internal nasal wall insufficiencies, and whenever you have a like open roof deformity, and when you want to correct the inverted V deformity, and sometimes you want to getting the good dorsal aesthetic line, then this is the indication of the spreader graph. So whenever you have the indication, then you use, yes. So now,
So there are some questions
Yes.
from the audience about like, do you have any workshops or fellowship programs for this rhinoplasty hands-on experience?
yes, we have the two programs, the Rhinoplasty Fellowship course. My ninth Rhinoplasty Fellowship course in the next month, 7 to the 12th April, and we have the 6 seats for that participants. So my next course is fill, and then you can apply my next in the October. So that is the 1 week hands-on training sessions. We have hands-on training sessions in my OT. In the morning, we have the lecture and then fellowship exam. And then day one, we have the cadaver demonstration. So we learn the anatomy. Yes. Now, वो देना, वो cartilage देना, एक बार suture, big cartilage देना. So before to close that, 15 number blade देना, 15 number blade देना. So this is my cartilage. अपने पास यही है ना? This is my cartilage. So before to make the carving, you should have in your mind what you want to do. Yes. Now, yes, we have this one also. So this is my graft. So I just reconstruct the anterior part of the septum just for fixation. So whenever you reconstruct your anterior part of the septum, then you later close this one, that is easy for you. Less like hold. So just we have like this. And then just we check the symmetry not beyond your dome region. एक बार ऐसे रखो, इसको भी लगाओ इधर, because we want to reduce the axis columella show. ठीक है. Just so it's the very important step. Then someone asked, then there is a retraction of the columella. So if you fix this graph just like this, then you over rotate your nose. And if you want like this, then you create the problem again. So this graph that should be straight, and then ideally uh, it should be just at the anterior level of the margin of the medial crust, but in this case we have some different, like we want to reduce this axis columella show, so just we fix it little bit behind the margin of this anterior margin of the medial crust, and then just we fix it like this. Suture lateral crust retractor lagao. So it's very important because there is a lot of my friend think that why not you use the columella strut in this case. Definitely you can use columella strut because sometimes your patient doesn't have any change in the dynamics of your tip, then definitely you can use just for reconstruction of your interdomal support. But this patient need little bit orientation of the tip, so that's why we use this graft.
Sir, there is a query
Yeah.
from beginners of surgeon.
Yeah.
How to contact you, and is there any channel or group for this?
You just contact for any course or regarding with my fellowship coordinator, and doctor, you can contact to my Dr. Rajveer also. And then I have the two channels. You can find me on the Facebook also, and there is a Rhinoplasty Education Group of India. If you can find me, mostly my surgery live there, and I have a channels of YouTube also, Dr. Sunil Tawar Rhinoplasty Academy of India. So I have a lot of my all types of the surgical videos there, and all cadaver dissections also. So that is, I think, maybe useful for my beginner friends. And you can put your comment also. Then definitely, whenever we have the time, then we discuss regarding the particular your problem. And you can also comment on my Facebook group also.
Sir, any contact number directly you can share?
Contact number, that is, you can just share the flyer. I think the 900-183 6112. That is the coordinator of the course. 900-183 6112. That is the number of Mr. Narendra, that he did all these things.
Thank you, sir.
Yes. So we fix this septal extension graft in side to side manner by the mattress sutures. You can fix it by end to end manner also, but that is little bit difficult when you fix it like end to end manner. Now, just cut it. एक छोटा ग्राफ देना मेरे को. So we just put the small. अपने पास cartilage है और we have कौन सा cartilage है? This one. We have this one. Okay. लो एक बार देना, needle देना. So I just put this small graft as a batten, and then we fix this rest of anterior graft. Yes. Now. So it's depend on you, when you have the cartilage available, then you can use as a pattern graft. and you fix by the two double knot for fixation of that. मेरे को ये दूसरा चाहिए. For PDS suture, I need more correction. Cut it. बड़ा काटा आपने.
Sir, question from Dr. Gorakhnath, Uttar Pradesh.
Yes.
Why don't you cut the extra ULC?
Definitely, we can cut the external upper lateral cartilage and then we can use. That's why I'm saying a case have a different manner. How can you do? Because in rhinoplasty, there is no single technique by which you can complete. And it is the choice of the individual surgeon. It's the choice of whatever you have the deform. Because in this case, the reason behind that, because I want to little bit more width of the mid vault, because when I examine this patient, then I feel that this mid vault is a little bit narrow. That's why I use. Otherwise, that you can excise.
So, question from Dr. DG Delhi.
Yes.
What if nylon or proline is used instead of PDS?
You can use. I usually use the PDS suture because that have the more good strength. I think I'm not routinely use that sutures. Otherwise, you can use.
So, question from Dr. Kalyan Kumar Singham Shetty, Andhra Pradesh.
Yeah, Dr.
What is the preferred graft material for dorsal augmentation of the costal cartilage, conchal cartilage, diced conchal cartilage in temporalis fascia?
Dear, basically it's depend first how much you want to augment your tip, how much you have the deficiency on your dorsum. If you have some simple like minor depression on the dorsum, then you can use a double folded conchal cartilage, that is the enough. And if you have a gross depression on the dorsum, then definitely the costal cartilage have the only one option. So the costal cartilage is the good options for correction of the when you have a extensive depression on the dorsum. And diced cartilage is also only for the designer graft, just for getting the more definitions only. So it's a matter then how much you need the basically augmentations in the mostly saddle nose. um, I think the coastal cartilage is a good source because when you have a lot of amount of the saddling, then that is the good. Otherwise, you struggle a lot. Because sometimes when you harvest the conchal cartilage, but that is the not enough, and later you struggle unnecessary. So now, and there is a different manner then how can you use the dorsal graft. You can use as a integrated L stud. Sometimes you find that with the dorsum your tip is also so depressed. For the reconstruction of that you can use as a integrated L stud graft. And sometimes you have the tip good, then you just use a single dorsal graft. So there is a different way to correct the different noses, different deformities. Yes. So the entry and the exit of your suture, that should be the same. So this is the horizontal mattress sutures. So if you put this suture before to reconstruct this part, then it's difficult. So first you reconstruct this anterior part, then cut it. So at least the things are the stable. Now we stable this part of the.
So Dr. Kavita from Madhya Pradesh is asking
Hmm.
what suture he had put on upper lateral cartilage and why.
Upper lateral, in the rhinoplasty, I have a rule that whenever you fix the two structure, then you need the two good grafts. Okay. Then you need the good suture. So I usually recommend 4 OPDS and the 5 OPDS suture. And when you have a coastal cartilage, then the 4 OPDS is the good because it's very difficult otherwise when you pass. So I usually recommend the 4O PDS sutures.
So Dr. Madhuri Mehta from Haryana says, Dr. Sunil, beautiful, remarkably well done surgery. Could we have used a single L-shaped septal extension graft in place of two pieces?
Yeah, good afternoon, madam. Really, we can use sometimes suppose your patient have a, like inferior part of the septum is absent and we have like in we just generally saw in the post septoplasty cases we have a residual dorsal part of the septum. In that case you are right, then we can use a L sept or fan sept graft. So the longer side we can suture with this part and then this part and then we reconstruct the inferior part of the septum. So you are absolutely right, we can use that L sept graft also. Yes. Because there are so many techniques in the rhinoplasty. So how you are more confidential, how your learning, how your professor is doing, how you are more confidential. So according to that, you never just follow like the someone that you just only rigid only one technique. So I just fix this. And in rhinoplasty, like sometimes when we feel the graft is not good, technique is not good, I think you just will take time, but you open it because otherwise the patient creates the nuisance. So it's the very important thing. Yes, we suture this one. Yeah. Irrigation करना. For my beginner friends, like if you suture, then you first suture like three structure whenever you use the spreader graft, then first the septum and both sides of the spreader graft, because all five structure suture is little bit difficult. So and then after fixation of the three structures, then you can use the rest of all five structures, because usually we don't have a big needle in the India by any company. Recently in our SICON meeting, Dr. Gaisa said me that definitely he have a company person that have a long needle, so that is the good. So it is easy to fix that.
So Dr. Parag Bhayal from Madhya Pradesh is asking,
Yeah.
instead of mattress suture, what if we use continuous interlocking suture?
You can use, I usually use these mattress sutures. So advantage of that, if you find that something is wrong, you open only one suture, but sometimes when you use, then entire assembly is free. This is my logic. Otherwise, you can do definitely. If you're doing frequently that definitely you can do. पैकिंग फॉर वो देना मेरे को नीचे अंदर पैकिंग करने के लिए.
So question from Dr. Arpit Agrawal,
Yeah.
Delhi.
Fajal इसको बताओ.
What's your preferred way to correct severe crooked noses? Is it extracorporeal for you as well?
Yes, it's a matter of the big debate, dear. But in my routine practice, I'm not routinely doing. It's very rare because regarding the extracorporeal septoplasty, Dr. Gubis, I think he's the founder of this extracorporeal septoplasty and the follower of that. They're doing beautifully the extracorporeal septoplasty. Recently, I am in the meeting of RC Khan, Dr. Gaisas and Dr. Hina Bakshi. They do the extracorporeal and the partial extracorporeal, but I think it's not necessary. Then that is the only technique by you can correct the crooked nose. I'm not routinely do the extracorporeal septoplasty. So, uh, uh, but if you have a lot of experience, because after removal of the entire septum, if you put it again, then it's very difficult. So it's a matter of again. I usually basically this open septorhinoplasty and there is no need to use like extracorporeal septoplasties.
So Dr. Shyamla from Tamil Nadu is asking, any use of stapler instead of sutures?
Stapler in the nose, I heard first time. Cut it. I lot of meeting the national and international, but I never saw. Maybe Dr. Shamla, you have the experience. I don't have much experience regarding that. So now we come down, we reconstruct the mid vault, we come reconstruct the anterior part of the septum, and now we come to the tip, that is the 6G step. So because in this patient we have to correct this malposition of this lateral crus. So first we separate this lateral crus from the rest of the underlying attachment. पहले मेरे को एक सीजर देना. Give me the seizure. Give me the seizure. Give me the seizure. So first पकड़ना. इसको पकड़ो यहाँ से. Because this patient have the cephalic malposition of this lateral crus. So first we separate from the rest of the underlying attachment. Sharp seizure देना. Give me the sharp seizure. Give me the sharp seizure. Yes. And you hold this one. So this is the little bit difficult step. You can use the hydrodissections for the separation of the vestibular skin. So now I separate. Yes. यहाँ से पकड़ो. मेरे को थोड़ा टेबल ऊपर करना है. एक मिनट. नहीं तो मेरा बैक कक होगा. Yes. So now just आप लगाओ. So just we separate. You can use like local infiltration also, but sometimes when you have a buttonhole, then because sometimes female patient you have a very thin skin, so I separate my this lateral crus. अब आप छोड़ दो इसको. Just इसको दो. अब नीचे लगाओ. So the importance of the counter traction is less. Yes, ऐसे पकड़ो. And the suction, give me the suction.
Suction on.
Suction on करो. And ये राजवीर को देखना, इसमें focus करना proper. And then you can use the periosteum elevator suction. So you can use the periostem elevator and you can use the seizure. I usually use the seizure for separation of this like this. अब यहाँ से लगाओ. Throughout the role of the counter traction is very important. Yes. So we just separate from the rest of the attachment. If you feel like the problem for my beginner friend, then you can infiltrate. That is easy because sometimes otherwise you have the buttonhole. And now just yes. So again, yes. So now I remove that. And now this is my scroll area. So I not damage my scroll area, 15 number blade. This is my scroll area. So I just yes. So now my lateral crush is free. Now on this side is also. Yes. So again, the counter traction is important. Otherwise, sometimes you have a buttonhole. So first you find the good plane. यस मेरे को इधर थोड़ा दिख नहीं रहा थोड़ा सा ऐसे करो यस मूव करो यस सो फर्स्ट वी सेपरेट एट द अटैचमेंट यस इसको पकड़ो यस क्लीन करो यस अब टूथ फोर्सेप्स से पकड़ लो छोटा बस यस दिस इज द एनफ दिस इज एनफ so now first you getting the plane and then you separate yes इसको छोड़ो यहाँ से because sometimes when you have the buttonhole then you never the panic yes now ऐसे पकड़ो यहाँ से इसको यूं just like lux yes so your role of the assistant is very important and you are in the right plane counter tractions that is always important otherwise you struggle lot yes इसको yes so laterally this lateral end of this upper lateral cartilage this lateral crus attached with a chain of accessory cartilage ये बताओ now I just make this is the scroll area so I just make 15 number blade yes so now we free the both of this lateral crus we check the symmetry of the both of this lateral crus irrigation saline irrigations saline irrigations saline irrigation gauge piece and cold saline उसको बोलो यहाँ पे cold saline मंगाओ
Fault line.
So we check the symmetry of both. So sometimes when you have a asymmetry in the both of the media, this lateral crust, then you can trim it and then you can just make, ideally this is both is equal, so there is no need to much trimming or something. Yeah. So this is the caudal margin of the lateral crust. This is the cephalic margin of the lateral crust. So look that if you check the orientation, this is my medial canthus. The orientation is like this. We want to change the orientation that we have support the anterior margin of this ala. Now we have this small cartilage. One is this one and लाओ ये दो मेरे को, जस्ट पकड़ो इसको, वहां पे बिटोम के नीचे करो. We have this one. Knife. Knife. What is the time?
No, 2:10.
So knife. मेरी हेडलाइट की बैटरी चेंज करना. Because this is the inferior part of the septum. This is the inferior part of the septum, so I just thin it. And now this is the, yes. 4 OPD, 5 OPDS suture. ये गिर जाएगा, इसको उधर रखो. So this is the small part of the cartilage. Now we want to reposition of this graft. So I think we need some stuff material just to refix in the new position. So either we have the two way, either we fix with this lateral end of this lateral crust like this or like this. If we fix this like this, then we say that is the Ella Batten graft, just for my junior colleagues. And if we fix like this, then this is the lateral crested graft. I personally like this lateral crested graft because this is the good, because this part have the pushing effect upside. So that's why usually I use this lateral crested graft for reposition of this one. Yes.
So there's a question from Dr. Arpit Agrawal again.
Yes.
Whenever we use septal extension graft with side to side suturing, is it advisable to decide which side of septum to suture the graft depending on the convexity or concavity?
Yeah, you can fix the opposite side of concavity. Opposite side you fix, that is the better. ला ऐसे पकड़ो.
So a question from Dr. Reena Arora, Madhya Pradesh.
Yes.
Does
ऐसे पकड़ो.
installation of cold saline make difference?
You know, sometimes something you feel the comfort in your mind. I usually use the cold saline gauge piece also throughout the surgery, and the cold saline irrigations. I think if you use, I think you also enjoy the surgery, and otherwise you can do without that. But really, the field is bloodless, and then you can throughout the surgery when you have a bloodless field, then you enjoy regarding the surgery. Otherwise, regarding the results, I think I don't have any particularly effect of the cold saline regarding the results. So I use this 5 OPDS suture, and I put the suture, I fix by the two needles. Then like yes, one more suture. If you have the lateral crura stud graft with the costal cartilage, then I think um, you fix by a 4 OPDS suture because that is the little bit difficult otherwise. So at least two suture you need for fixation of this lateral crura graft like this. And I always use the 2 double knot, 3 double knot. If your patient have a thin skin like Dr. Vitali, he used the Vicryl for this purpose, and because he say that my note of the patient feel later, like on this side also. Love दूसरा वो देना graft. Give me the first. कहाँ है वो graft? ये है? This one? Yes. So this is the lateral crura strut graft. That is a very important graft for reposition, for the reconstruction of the lateral crest. यहाँ से पकड़ो. So it's just like pass the needle. I think one more needle you pass. Sometimes your patient have a binder syndrome and your you have a very weak lateral crura. Then you can use a strong long lateral crura stud graft for reconstruction, because in the secondary cases I sometimes find that because the lateral crest is too weak, so my beginner friends sometimes they left as the intact, and usually don't do the reconstruction of the lateral crest. But it's very important you reconstruct your lateral crest. Otherwise, if you find in the ala, in the supra alar region, you have a groove, and because the patient is happy when you use the dorsum augmentations, but I think you are not happy because when you see the tip of the patient, still you have a prominent groove in the supraalar region. So you reconstruct by a strong lateral crura graft. In that case, the length is long and you have a wide lateral crura graft till the level of the dome. And in spite of that, if you have the weakness, then you can use a articulated rim graft also. Yes, ये हटा दो, आप निडल की जरूरत नहीं है. Yes, आराम से छोड़ो छोड़ो इसको छोड़ो. Yes. So just superior to under surface like this. Because sometimes the needle is rotate and then like this. नीचे से आ गया उसमें. Yes. So we fix the lateral crura graft with the lateral end of the lateral crus by a 5 OPDS suture. Now we just again इसको रखो. Check the symmetry because the both sides that should be in the same. Just in the Namaste position of Dr. Kapil Agarwal. They have a very good technique to prevent the warping, the Namaste technique. Lot of international meeting also saw that technique. They follow the people for. So now we cut it the axis part. Yes. एक बार मेरे को वो देना, ड्रिल देना. है ना. So saline irrigation करना. saline irrigation करना. So the lateral end of this lateral corollateral graft, I just little bit in it because otherwise sometimes the patient feel this one. So I just make the good contour of this lateral end. Yes. Yes. Now, the other important thing where you make a pocket for insertion of this lateral corollateral graft. So give me the sharp scissor. Just for my junior colleagues, then where you make a pocket, that is a very important. So either you just stand behind the patient or just you identify your end of your lateral end of your marginal incision. So this is my margin of this is my lateral end of the marginal incision. So just look like the direction of the my seizure is towards the lateral canthus, and just I create a pocket just like in this way, like in this way, and the lateral end of this graft that is outside of the pyriform aperture, never on the inside of the pyriform aperture. If you put it in the inside of the pyriform aperture, then you develop the collapse. So this is very important regarding इधर भी लगाओ. So just we identify, सक्शन करो, साफ करो फील्ड को ना, ब्लीडिंग नहीं होनी चाहिए भैया. Then now again towards the lateral canthus, and I'm outside of the pyriform aperture. This is a important thing. This questions asked by in my board certification exam when I was appear in the Washington DC. Then where you fix your lateral corollateral graft. So I think it's a very important thing. थोड़ा सा confusing है. कोई बात नहीं, लाओ.
So Dr. Rashinkar from Karnataka is asking, what are the chances of rejection of grafts?
Why you have the rejection? If everything is good, then there is no rejection of the graft. The rejection of the graft when sometimes you have a the case of history of the 3 or 4 times surgery and your skin is not good and your graft is too thick, then is and your blood supply is poor, then otherwise usually the graft is not necrosed. La, tooth course of देना. साफ करना फिल्ड को मुझे साफ करना. Yes. So look that I just fix. Yes. ग्राफ फूट गया. एक मिनट निडल दो. We fix by the needle. निकालना नहीं है उसको. You pass the needle. You pass the needle. You pass the needle and give me the suture. Pass the suture. So now we reposition. इसको needle को थोड़ा सीधा कर दो. So we are doing almost in the last step of our G step that usually I recommend whenever you do the rhinoplasty, then the like first I fix the lateral end like in this way. इसको पकड़ो. थोड़ा ढीला मत हो यार. Yes, like so we fix in the new position. Yes. थोड़ा दिखाओ मेरे को. I have a very good assistant and he know each and everything. So I think your role of the assistant is very important, because in my all sometimes we have international meeting, then everyone appreciate to my assistant because he know each and everything. And sometimes he asked me, this patient need little bit more projections, and you remove these graphs like so. So when you do the more and more cases, then your team, that is, you develop your own team, that is really very important. Dr. Pawn is also fan of my assistant, then always they appreciate to Mukesh. Yes. So hold it. सक्शन करो, क्लीन करो, फील्ड को साफ सुथरा रखो. यस. Cut it. Cut. Yes. So now on another side. No. Now we have the good support. इसमें जो पैक निकाल दिया था ना अंदर से. So just we do force of देना. We just pass where we make the groove like this. And then yes. One more needle. One more needle. Yes. Suture. So laterally, I think you should fix first. So at least the things are stabilized. In rhinoplasty surgery, you need the lot of patience, because if you load the patience, lose the patience, and your assistant also lost the patience, then it's difficult. So this is the game of patience. So 3 note that usually you need. काटो इसको. Yes. ये needle remove करो. Yes. So we just put the last suture first here. So just we put this. My suture is the 5 OPDS suture. Yes. Yes, cut it. Now I think I need one more suture at the just medially. So I think that is good. You remove this one. And throughout when you fix, then you check the margin of this one. If your margin is too behind, then it create the problem. So then you fix like this, and then the same method. Suppose your patient have a like depression on this ala, then you just lateral crura flip technique. If your patient have a diffuse lateral crura deformity, then you cut it this lateral crus in this area, and then you flip it so under surface comes upside, and then you correct your lateral crura paradoxically deformity. Now, tooth forceps. So I just put one more suture. So now, yes. One suture, correct, cut it. Yes. Give me the gauge piece and give me the long needle. So we reposition this lateral crest in the new position towards the lateral canthus by the lateral chloroasted graft. Scissor देना एक बार. Now we just, yes, suction. Yes. Now needle देना. Long needle देना. हाँ, लंबी needle. So now we advancement of this medial crust on this part of the septum that we usually we say the tongue in groove technique. So the tongue in groove technique, suppose we don't have this, we use this part of the septum and we advancement of this part of the medial crust on the native septum, that is the classical tongue in groove. We reconstruct by this small part and then we advancement on that part, so that is the modified tongue in groove. So now I double हो देना white double prong. So this is the way. थोड़ा सा पीछे जाना है इसको, because we want to little bit just rotate this. So just and then just like yes, and then one more needle. You give me the one more needle. You give me the one more needle. So then like this. And then like this. And you check that both sides of your dome that should be on the same height. There is no discrepancy. If you have some discrepancy, then you remove the needle and you just fix again it. So both needle entry and the exit that should be at the same level. Suture. Suture. So then how we fix this? ये थोड़ा गैप आ रहा है यहाँ पे भैया. So like this. इसको पकड़ के रखो needle को.
Dr. Sunil,
Yes, boss.
the lower part, na? Lower part of the graft.
Yeah.
Trim it slightly.
This one.
Because it is making on furrow there.
Yes.
Lower
Definitely,
part
I
of the
think. In the last, I just make dealing of this just for smoothing.
Okay.
ला, वो देना. Once I fix, definitely, your point is absolutely correct. Then again, like this. Then, so this. So the advantage of this suture that your note that should be inside. I learned this from Dr. Kapil Agarwal boss. So this technique is very good technique. Then your note is looked at that inside. Yes, cut it. So now the note is the inside of your cap. Now you remove this one, both. Yes. And give me the 15 number blade, 11 number blade, then 11 number blade. Yes. Yes. Yellow.
So Dr. Santadeep Paun has joined with us now, and he has a message for you. Good morning, Sunil. Apologies, I just woke here in London as I had a late night, so have not seen the whole case. Why are you using lateral crural strut grafts in this case?
Yeah. Welcome, sir, and morning in the London. Because this patient have the parenthesis deformity and extensive basically cephalic malposition. So correction of that's why we use this lateral crural graft. I'm waiting, sir, for since long time that where you join because but lot of the time difference. I miss your.
My apologize. I apologize. I was out till very late last night, so
Yes.
I couldn't make it. But I woke up as early as I could to watch you. How are you anyway, Sunil? Good morning. How are you? Or good afternoon. Sorry.
Fine, thank you. Nice to see you there.
Always here to support Sunil.
Whatever
Sorry,
I'm
quick,
today in the
apologies,
rhinoplasty.
Sunil.
Yes, sir. Yes, sir.
Carry on.
Yeah, I'm saying that whatever I'm today in the rhinoplasty because of the Dr. Pon sir, I learn lot from and whenever we meet, then learn some new things. So I think like in the morning we have a brief discussion then how you start your rhinoplasty career and how you improve result. So the first thing you should have a mentor, you should have a teacher. Like in India, we say then Guru Bina Gyan nahi. So you should have a good teacher, good mentor. So I'm blessed with God. Then I have a good mentor and good teacher. Caesar Dena. Udena. I'm a number plate.
The problem is when you get called a guru, it makes you feel very old.
No, sir. No, sir.
Is that a septal extension graft or is
yeah,
that
it's the septal extension graft, sir. It's the septal extension graft. Okay. It's a septal extension graft that we use. So, sir, what is your opinion that what is the height of the tip? That how we decide that this is the ideal height of the tip?
I mean, and you've heard me speak about this before.
Yeah.
So you have to base your decision about the distance between your tip and your supratip area based on the thickness of the skin.
Yes.
And that's a critical thing that it's difficult to judge when you are young, but it's something you have to learn because if you don't project your tip beyond the dorsum significantly, particularly in the sort of patients that you will have in India with the very thick skin patients. And of course, but even within India, skin thickness changes enormously. So there's a huge variation from northern India to southern India, for example. And so you have to judge it. So the thicker your skin, the more the distance you have to leave between your tip defining points and that supratip area. And so in the very thicker skin and the very thicker skin that I treat is the Arabic skin, the Middle Eastern skin. you have to even leave maybe even about a centimeter between the two,
Right.
even more sometimes, because you will
Yeah.
always expect to get soft tissue
Yes.
infill. So just bear that in mind when you're judging where your tip is going relative to the dorsum, because you have to be just aware of the fact that there will be a little bit of discrepancy, and there's always going to be some soft tissue infill in that region.
So how much, I think in Indian scenarios, how much millimeter that you recommend, that is the
I'd say minimum 7 millimeters
yes,
for
yes.
thicker skin, but again, it depends on your skin type, because even in India, let's say there's a huge variation in your skin. So probably, if you've got very thick skin, it would go.
Yeah.
But for somebody like this, and you sent me the photographs yesterday, she's got medium thick skin. It's not that thick. So I'd say probably about 7 millimeters should do it. Because if you don't leave enough, you'll end up with a super tip fullness there. And not necessarily because you haven't lowered your super tip enough. It's just that there's always soft tissue infill, so you'll end up with almost like a soft tissue polybeak. So you've just got to counter that and be aware of it. Again, it's a judgment thing that's based on experience and everything else, and you've also got to do all the other things that we normally do in terms of steroid injections and various other taping and everything to reduce that fullness in time.
Yes. Yes. Suture देना. Give me the suture. 5O or 4O. 5O suture देना. 5O suture. सुचर मंगाओ ना दूसरा.
What zero is nine?
Poro suture. So in this case, I think you use frequently the cranial tip sutures and the Gruber sutures. I think mostly case you should change your practice nowadays.
Yeah, so, I mean, the Gruber suture is something which I changed. Again, the most important thing about when you're doing rhinoplasty is following your patients long enough.
Yes.
And I mean, as you know, I speak at various international meetings, and when you speak at various international meetings, you look through your own results. I mean, I try not to give the same talk at every meeting. It gets very boring. So if nothing else, you change the photographs and everything, which means you start looking through your own photographs and being hypercritical of your own results. And I think that's a good thing to be done. So the group is something which I saw, and I just wanted a little bit more eversion of my of the caudal border versus the cephalic border, and that's why I started doing that group of suture, which I think I showed you in Delhi when I was doing some cases in that case. Interesting, that lady in Delhi was really happy. She contacted me through Instagram and was delighted, and I'll show you her photographs. But on that, it really shows that tip and how it's improved because you've just lifted that caudal border up. When I get a chance, I'll show you her photograph. She's going to send me the post-ops.
Yeah, definitely.
But with her, again, we left about 7, maybe 8 millimeters between her tip and super tip because she was very keen on getting a super tip break. She was very smart. I think she was she is a influencer online, but I'm not sure. I think she's a architect or I don't know. But anyway, she's a pretty girl, so she's online and she very much knew what she wanted. And that's very useful for you as a surgeon.
Right. Seizure देना. So I use in this case oblique sutures, but I'm not convinced in this patient, so I remove that one. I use the conventional suture. I first try the Dean oblique sutures.
Yeah, I've moved to a sort of hybrid between the cranial tip and Dean's sutures. Now,
Yeah.
I do like a hybrid between the two, which I think gives me the maximum eversion of that lateral crus, and I think that's important. Maybe you should show that to the audience as well about the importance of the caudal border. I think it also improves function as well, because when you revert that caudal border out, it does improve the function and stabilizes the external valve.
ऐसे पकड़ना. Yes. So then let medial to lateral and again lateral to medial like this. So this is the different suture little bit rather than the conventionally when we use like dome creating sutures, because this suture in the oblique manner and just for eversion of this caudal margin of the lateral crust and usually the beneficial.
And you can see that very clearly on the screen, actually. When you put that suture in, it's made a big difference.
Really, it's a big difference. So for my beginner friend, then you can use the classically the intradermal suture, or one is the interdermal suture that usually you use for dealing the width of the tip and for getting the more definition. But again, it's a matter of when you do the more and more cases, the things are changed, your technique is also changed. So the intradermal suture that creating for more definition, the interdermal suture that for decrease the width between the two tips. Yes. ऐसे पकड़ो. So this is the interdermal suture. This is not too tight or not too loose, otherwise you create the problem. Yes, cut it. So this is the interdermal sutures, and now this suture, 4 PDS suture, 5 vital sutures है, 5 या PDS दे दो. So I put the one more suture behind that. That is, we reconstruct this scroll area. One of a participant that is asked. So like just we make a suture with the this cephalic margin of the. So this is the scroll reconstruction suture that we use. Yes, on both sides. ये और है क्या दूसरा lateral crest? Lateral. Sir, in your patient, like you preserve the pitangui ligament, because there is a lot of debate regarding that. What is your experience regarding that, sir?
I'm not obsessional about it.
Okay.
I think it's in many ways the thicker the skin, I think the less helpful it is. I know it's sort of said that but I think the thicker the skin, and often, as you know, I like to take away some of the soft tissue from underneath the skin.
Yes.
As part of using the Adson forceps, as you've seen me do many times. And in doing so, you often take away the pitangis as part of that. So I'm not obsessional about it. If it's easily preserved and easily you can stitch it back together again, I will from time to time, but I'm certainly not. It's not part of my routine that I will obsessionally preserve Patenges. I'm not sure. Certainly in my practice, and certainly for the patients who I see,
Yes, sir.
that it makes a huge amount of difference.
So
The one thing I'll say to you, just Sunil, when you put your interdermal suture in,
yeah,
as you
yeah,
just did,
yeah, sir.
you did it as a horizontal mattress suture.
Yeah, sir.
One of the risks of that is it can sort of, again, just narrow that angle. And if you put
Yeah.
it in just like you are now, like just a normal suture, like you're doing, so you're doing an alar sort of spanning suture now.
Yes.
So if you
So
do the
this-
very similar,
Yeah, similar look that when we put, then the change the margin of the look that the margin of the
correct,
this one. So we invert the margin of this is the
Yeah.
effect of this suture.
Yeah. So if you do the same suture, even with the interdermal suture, which you
Yes.
did, so the interdermal
But it-
suture you did as a horizontal mattress. But if you did it as just a straightforward suture, just like you've just done now, then again it causes eversion of that lateral, the caudal margin, and it's another thing you can do. So lots of different ways of reverting the caudal margin.
देखो है. Yes, you are saying the right. So this is my perichondrium. I just on the one suture. So this is the advantage getting good contour. I preserve my this perichondrium when I use in this case a spreader flap because the mid vault that is little bit narrow. So this is the advantage. I preserve the perichondrium and now I suture the perichondrium over the mid vault. So there is no need to use any like the temporal fascia or something. Cut it.
Again, probably less relevant in your skin cases where you've got thick skin, but very
Yeah.
important when you've got thin skin to try and
Yes,
preserve
then
as much as
sometimes the note is feel.
Mm.
Cut it.
So you mentioned Dr. Kapil's Namaste technique. I haven't seen that. Explain that to me.
Yeah, definitely. We discussed at the time of the osteotomy. In this case, I did lot of rhino sculpture, not the osteotomy, but definitely we discussed at the time regarding the osteotomy, all type of the osteotomy for my beginner friend. We discuss. I do the rhino sculpture is the lateral nasal wall, and because she have a big bump nasal speculum.
So Kapil, I'm going to have to come to Mumbai to learn this new technique from you and get some singing lessons as well.
Yeah, sure. You please come. We will have a fun here.
We'll do some karaoke together.
Taking
Yeah,
forceps.
please come. Give us a chance.
Sixovical rapid. Sixovical rapid.
For those of you who don't know, Dr. Kapil is affectionately known as the singing surgeon. He's amazing.
He have a very good technique of the Anaplasty also, sir.
Yeah, he showed me the prize he got. I think the BOPS or ISAPS or.
So now I put the quilting sutures. Give me the quilting suture, orovical suture.
So Sunil,
Sir.
you have some depression in this area, the supratip area, right side.
Yeah.
Yeah. This side only.
Just we check.
Or your tip is actually turning towards right side slightly. I think this graft is tip graft you have put, na?
I
It
think
is
we check.
bending towards right side.
Yes, just we check. Section देना. Section देना. First we make this quilting suture, then see. La, laser speculum देना.
Just a comment, Sunil. I think again for those who are fairly new in rhinoplasty, when you do that sort of when you mobilize the whole lateral crural complex and then you put lateral crural strut grafts and you reposition like you did with the lateral crural, it's very easy to get asymmetry. So before you start doing these cases, make sure that there's a good indication for doing that case, i.e., mobilizing that lateral crus, because it's very easy to end up in a lot of trouble and ending up with really quite significant asymmetries of the tip, etc. So, and you've done it very nicely, and you've sutured it in position, but it is a tricky thing to do. So, often people go to meetings or watch videos like this, and then the next day they try these things, but just be careful is what I'm saying, because it's very easy to create asymmetry.
Definitely, sir. One should do the more and more cases, but really, it's little bit difficult because when you separate from the vestibular underlying mucosa, that sometimes the buttonhole, and when you have a weak lateral crust, then so I think at that time you can just infiltration for the better hydrodissections we can use. Yes. Yeah. Cartilage है अगर पे वो देना नेजर स्पिकुलम उठाओ. So office retractor. So Kapil was on look that now after the quilting sutures, now both sides are the equal.
But still you have some depression on the superative right side. You put something there.
So we just put little diced letter 6-cervical leopard देना. Give me the 6-cervical leopard.
What is this?
Give me the 6-cervical leopard.
What is a small bump there in the left side?
यहाँ पे this one.
Yeah. This one. This is seen. Yes.
This one.
Yeah.
Right.
Something there inside. See?
Yeah. We just see. We have a look.
Not, I think not your sutures. Not, I think.
Yeah, because this is this part you cut it this one. Because this is the bony part that.
Small thing that they seen outside.
Yeah, really.
This is suture, I think, this one.
Yes,
this is suture.
That's why your guidance is important. And the suture also.
Yeah.
So we
not,
just
sutures not is there.
हाँ. एक डाइस्ड है ना हमारे पास, डाइस्ड में बनाना 6 cervical rapid and irrigation राजवीर को बोला कि वो डाइस बनाना, राजवीर को बोला ना. So now we close in the last. So I learned the technique, like 5-tip suture technique from Dr. Pond. So first suture at the center, and then, because this is the only and only one disadvantage of open rhinoplasty. So if you suture meticulously, properly, then the patient is happy. So first suture that exact on the midline in the center part, and then sir, what suture material usually you also use for the closing your transcolumella incision?
60
Fixo
ethyl one.
Rapis.
Yes. So then
I moved to a 6-0 Rapide
continue.
many years ago, as you know, Sunil. Really because I don't want to have to remove the stitches at a week or 10 days. And that really changed after I had one clinic where I had 3 patients who were removing the stitches on, all of whom fainted. The 3 patients in a row fainted as I'm taking the stitches out. And I thought there's got to be a better way. This is too much hassle. So I moved to 5-0, 6-0 Rapide, and actually the scars are exactly the same. We did a review of the scars using the Ethelon or Rapide, and you get exactly the same scars. The advantage is you don't have to remove those stitches afterwards, which is, I think, nicer for you and nicer for the patients.
Yes, really, this 6-0 Vicryl is very good, and but it's little bit, I think, when you make, then you use only the wrist movement, because if you are not used to that initially, this little bit difficult to make the suture, but later once you do the more and more cases, that no problem. But you always ask, then whenever you make the suture, always use your wrist movement, cut it, and you have a good Medicon needle holder for this suture. So after the central sutures, we put the suture on either side in the paramedians, and then on corner sutures. Dr. Kapil was, when you remove usually your this transcolumella suture, when you remove usually?
7th day.
Chota kato, 7th day.
7th day I cut from the front only, and lateral side I leave for 10 days. Because many times whenever we are doing augmentation rhinoplasty, some tension will be there on the sides of the columella. So usually initially I used to remove all sutures in 7 days time, but one or two patients they got a slight gaping. So then I maintain the lateral sutures for 10 days, and front suture I remove in 7 days time.
Okay. And when you remove your plaster?
Plaster I first plaster I change in 7th day, and usually I keep for 2 days. 2 weeks.
Okay.
In any case, because the patients are very desperate to see the results, so I don't want them to see the swelling and other thing. In 2 weeks time, everything is settled. So whatever small thing I do, I keep the plaster for two weeks. Otherwise they eat my head.
So second time you put the plaster again?
Yeah, for 7 more days.
Okay. We usually remove the plaster on the 10th day.
No, I change on 7th day when I call for the suture removal. I change one plaster that time, and then again I call them after 7 days.
Okay.
So the maximum swelling is subsided in 2 weeks time.
At least 14 days now. The edema is also subsided
They
properly.
are away from you and they won't eat your head. Otherwise,
Yeah.
because of swelling, they will keep calling you or keep sending messages.
So now I make the marginal incision closing. So once you close the marginal incision, then the important thing, you just pass your needle through the only the skin to skin, not through the cartilage. If you pass through the cartilage, then you create the notching sometimes. So these are the some small things that affect the results. Yes, I double prompted that. And you also use was the same suture material or some another suture?
For columella closure, I use 60 ethylone or a 60 proline, one of them.
Okay. Okay.
Yeah. That's why I call them on 7th day for suture removal.
Okay.
The question I have is, do you remove the sutures or do you get the nurse or somebody else to remove the sutures?
No, I only remove the sutures because I have that fear that if they pull the suture wrongly, that the gaping will be there.
So you're pretty diligent. You're seeing them at 5 days, so 7 days, and then you're taking the plaster stitches, and then you're seeing them 2 weeks later. Or wow,
So that, that is a good thing because the edema is also subside, and at least the 14 days the patient keep the patient just to see the nose cut. That is a good thing.
I kind of if I had to see have to see every patient like that, I think my clinics would be over bulging. But I tend to go halfway house. I go to 10 days, and I think the beauty at 10 days, it's much easier to remove the plaster, and a lot of the swelling is beginning to settle at 10 days. So it's much easier because the plaster comes off pretty easy and the swelling is there. So I've kind of compromised and made it into 10 days. And it doesn't matter because you've got Vicryl Rapide, so you don't need to remove the sutures. Try it, Kapil. It'll change your life. You won't have to keep seeing these patients all the time.
No. So sometimes when a patient have a wide flaring of the foot plate, then sir, how you deal with that?
You're asking me or Kapil?
Yeah. When sometimes excessive like flaring on this foot plate, then how you just.
So what I do is I make a little stab incision on both sides percutaneously.
And
then I put then I put a 5/0 PDS suture through it. I mean, you're using just a Vicryl Rapide there, and that's fine, and that'll bring it through. But sometimes once that Rapide goes, if it's very wide, it will just flare again because the Rapide isn't there long enough to hold it. So if it's very wide, then I'll remove a bit of soft tissue between the medial cruri and sometimes even resect some of the medial crural foot plate if required. So sometimes if it's very wide, you have to remove the medial crural foot plate. But most of the time, it's just a little flaring, in which case I'll just make a little stab incision on both sides and then put a 5/0 PDS between the two sides and bury it so that it doesn't come through the skin. Because you can put a 5/0 PDS percutaneously, but then they feel it. They feel this little sort of notch, and sometimes it creates a little irritation there as well. And then you have to treat them with cream. So I just bury it and stick it underneath the skin, and then close that little stab incision.
And you use the skin contour suture, sir, nowadays or not?
The Vitalis ones.
Yeah.
No, I don't. And I spoke to Vitali 2 or 3 times about it because it's an interesting idea. But he said that at 2 weeks, he said at 2 weeks, he still sees the little depressions where he puts those sutures in. And that worries me because by far the most of my patients at 2 weeks want to go back to work. You know, they take 2 weeks out from work or they work from home for 2 weeks or whatever. But at 2 weeks, most of my patients want to be back to sort of some degree of normality. And I think it worries me. I might try it on a patient who's not working or something like that, but I haven't thus far tried it. But it worries me that if you're getting dimpling of the skin at 2 weeks, that's a bit of an issue. So I haven't tried it. I often will do. One thing I do sometimes is, again, in thick skin patients, instead of putting those sutures in, I put a little splint. So I put a little splint externally and internally, and then sort of compress the dead space. But there's a splint in place so that it doesn't, when you take the splint off in a week's time or 10 days, when you take the plaster off, it's not going to show. So I just use a little, almost like a batten on the outside and the inside. I just use a normal splint for that, the blue splints or whatever you have, salad stick or whatever.
But
And to compress the
he
dead.
used in some mostly cases, and he always told that I don't have any issue regarding that. He
No,
used
no,
so
no,
many.
he doesn't. I don't think he has. And I completely believe what he's saying. I don't think he has an issue at long term with it. But he says that it does. The dimpling does hang around for a while, and that's my concern. Is that it's a good idea. I mean, it's a nice thing to close that dead space and have sutures closing that dead space. But like I said, I just don't think my own patients would tolerate more than 2 weeks of having some sort of deformity. So, you know, by far, most of my patients take 2 weeks out from work and then they want to get back to work at 2 weeks. So if they've got even that little bit of dimpling, and that this is the slight downside with using Vicryl Rapide sutures is you can get slight those Vicryl Rapide can still be there at 2 weeks. So when they go back at work, so what I do is after, when I see them at 10 days, I get them to start rubbing at the stitches with a cotton bud with warm water so that the stitches begin to come away. And then
Profile view batana, lateral view. Yeah,
that's nice what you did. So Sunil, I think there were some few little irregularities, and I think you've improved it with the
so the lateral view batana yahan se dekha na. Because earlier he have a lot of the bump on the nose, and the nose is just like two projections, and there is a little bit tenting in this area. Caudal part of the septum is deviated, and almost now both sides of the nostril is equal. So I just show the profile view. वो देना जेलोनेट
and I think that last little finesse that you added by putting a bit of free dice cartilages smooth things out, because you were certainly seeing a few little irregularities there underneath.
Yeah, definitely. So basically it's the saline irrigation. Okay. So now we have the almost the like this. This is the profile view. So on the both sides. Yes.
Yeah, nice man. Very nice.
वो जेलोनेट देना, जेलोनेट देना.
Sunil, very good.
Thank you both. Thank you. So now I just put the because in routinely I am not put the Merosil in my cases until unless I don't have any history of turbinate dealing, because sometimes when we have extensive turbinate hypertrophy, then sometimes we do the turbinoplasty or turbinectomy in extensive cases, then we put gelonate. Otherwise this is the simple sofra tuli. मेरे को देना, बना के पैकिंग देना, so that we pack on the both sides. That is the good. So that just ये show करना है कैसे बना रहे हो. So how my assistant Mukesh is making this simple software tuli. So just this is the simple software tuli dressing. उसमें दिखाओ.
So Sunil, do you have a small graph left?
What you saying?
Do you have a small graft left?
नहीं बॉस अभी ग्राफ नहीं है.
अच्छा अच्छा ठीक ठीक.
So we just put it on both sides. Cartilage थोड़ी है कोई. Cartilage. So we just put like this. And tincture benjoin. Tincture benjoin. Tincture benjoin. So these two small piece on just for good approximation of the marginal incision. Rajveer ka? So I just apply this simple tincture and benjoin for as an antiseptic. Sir, in these days in London, you just applied steri strip or not, or you use usually the thermoplast, sir? Right.
No, I use so I don't use tincture benzene. I just use a
Rajveer को
steri
बुलाना.
strips. I use steri strips. I use a little
video
non-stick
बना लेगा.
dressing just over the dorsum,
Video बना लेगा.
something like telfa or melanin, so that when you're taking the plaster off, it just comes off the dorsum a little bit easier. And then I use plaster of Paris. I just like simple plaster of Paris.
Okay.
And the reason why I like plaster of Paris as opposed to anything else is I can feel you can feel the tension, your pressure you're putting on the bones. If you're using certainly any metallic splint, it's very difficult to know how much you're pressing. I'm not a great fan of metallic splints, but you can use those hot what do you use? The thermosplints.
Steri strips.
So no, you use thermosplint, don't you? I think.
We usually use this POP cast because
Yeah,
the
I
six
like
layer.
I like POP because, as I say, it just for me it helps me just feel exactly how much I'm putting pressure on the bones at the end. You know, a cast is never to make a good. Putting a bad cast on can make a good rhinoplasty bad, but putting a good cast on can't make a bad rhinoplasty good. So you just got to be careful when you're putting casts on that you know exactly how much pressure, because if you put pressure on one side and then compared to the other side, you may get differential healing, differential movement of the bones. I mean, I think it's very easy after a long operation just to put a cast on and don't think about it. But ultimately, that cast is incredibly important.
Because some people are very rigid, they usually use the thermoplast and they not used any stereo strips on under surface.
Yeah, no, you can't do that. You have to use steri strips, and yeah, you're doing exactly as I do. I like that sort of contouring, and you can cut it, and you can make it exactly how you want to be. And I like that. I tend to use 5 layers rather than 6 layers because I find that's enough. But 6 layers is fine. And then, like I said, the only difference is I tend to use steri strips rather than, but you can use micropore. It's the same. And I tend to put a little bit of just a little bit of something underneath the skin vertically, just so that on the dorsum, just so that when you're taking the plaster off, it's a little easier to remove the plaster, but it's fine. Plaster of Paris is cheap, it's easy, it's
and good malleable also.
Yeah, it's very malleable. That's the key. It's malleable. And I think the really key thing with the plaster is this is the thing that the patient looks at for the week or 10 days or however long you leave it on for. And if your plaster looks terrible at the end of surgery, right, then the patients are going to, they'll be calling you, every day saying, "Oh, my plaster looks, it's not straight, it's not, And the other thing is, as you know, the plaster, because it puts pressure on the underlying skin, it molds the underlying skin. So when you take the plaster off, your nose looks like what the plaster did. So even if your nose is dead straight, but you put your plaster on slightly deviated,
Because first, at least it's the plaster.
yeah, well, for the first few days, it looks like what the plaster did, and then the patients are panicking, saying, "Oh my God, my nose is." The nose may be perfectly straight; it's just that your plaster wasn't. So I think just spend a bit of time at the end. I mean, it's very tempting after the end of a big operation just to kind of want to just put a small, put a plaster on and not, but it's worth it. I think it's spending 10 minutes putting a decent plaster on, getting it right, given that that's all they're going to see for the rest of their time.
Yes, definitely you are the perfect, sir, exactly. So we use this 3-layer. First, we applied the tincture benzoin just as an antiseptic, and then the 3-layer of the 1 layer of the steri strips, and then this POP layer, and then again this, because sir, you have that there is a brown tape that is a good, but we don't have we don't have. I'm not fine
Let
that.
me tell you a story about the brown tape. Okay, so I was once in the Middle East. I was operating on a VVIP patient out there. He was one of the royal family patients, and they were so happy with the plaster, post-operatively, because of the brown tape, and she just, actually she woke up, and when she looked at, because she was a little bit sleepy, when she looked in the mirror, she thought I hadn't even put a plaster on because it hides. Right, and her family came and it was dark in her room. They couldn't see the plaster because it was so beautifully camouflaged by the brown tape. Anyway, they were so impressed with this brown plaster, and she got a good result. But she, on the back of just the brown plaster, she sent me about 10 patients, and every single one of them said, "But please make sure you put the brown plaster on. Please put the brown plaster on." So, like I said, these little bits of attention to detail are really important for patients, because ultimately this is all they see for the first week to 10 days. They just see, and if you've got a massive big cast on, they look at it and they think, "Oh my God." And if you put a beautiful small plaster on, it just shows it reflects the work that you do. So spend a bit of time making your plaster neat and tidy, and you'll be surprised how much work you get. It's the same with sutures. If you suture beautifully, the patients see the suturing and they think, "Wow, this guy is a very talented person."
Exactly, sir. So thank you, and we finished the case, and really, once again, thanks to my bottom of heart, the Abbott, the ZBM, Mr. Satish Sharma, and the Dr. Umi, because sir, last 1 month throughout, they continue doing the exercise for doing the hard work for good, successful making the event of this one. And I think everyone learned the new things, and the learning never ending. And thank you, sir, because you joined, wherever you join, then we learn something new. Dr. Kapil Agarwal, boss, and you, sir. So thank you so much. Boss.
Dr. Salim. Yeah, you have wonderfully actually demonstrated the surgical anatomy and all steps of the surgery, and nice result you have got. I'm sure that all delegates and attendees might have benefited a lot. Thank you
Yeah,
very much.
definitely, because boss, my focus is always to my beginner friends, to my trainees also. They I think after the surgery they think that I can do the rhinoplasty, not like thinking that I never attempt the rhinoplasty. So I think they everyone can do the rhinoplasty if you have a good sequential step, if you have a good anatomical knowledge. That's why this 15-minute session previous I just start how you start your rhinoplasty career. Once you start, then how you improve your results. So I think everyone enjoy regarding the surgery, and you have any questions regarding that, and then definitely you can ask on my the YouTube page and on the Facebook page also.
Dr. Sunil, I must say it was a very insightful session. I really thank you. On behalf of the entire Abbott team, and thank you so much for your time. I would also like to thank Dr. Rajbir and the entire staff for their assistance. And thank you so much, audience, for joining with us today and making this event a big success. Thank you once again, Dr. Sunil. With that, we would like to felicitate you.
So I would just like to add that we had more than around 2,200 people joining in from
Wow.
across India.
Okay.
And at the relay centers that were in the 9 cities across India, we had another 180 people joining in through the relay centers. So good doctors have joining, sir, and thank you for engaging them throughout this whole session. It was only a 3-hour agenda.
Yeah,
but
that is our motto. That is our motto.
till 2:30. So thank you a lot, sir, for engaging with the questions and also the responses that you gave that were very well appreciated by all of us here at Abbott. So just a token of gratitude, sir. To
Yeah.
Dr. Urvi, yeah, please. From our end. Yes. So thank you, sir.
Thank you. Thank you. And my especially thanks to again Dr. Kapil Agarwal and Dr. Sandeep on, because in the busy schedule on the Sunday, they join this event. Thank you, sir. Thank you, Kapil boss.
God bless you, man.
Thank you everyone for joining in. Thank you, sir. Okay.